Okay, so let's start. Hello, everybody, wherever you are around the world, and welcome to this special event of the World Federation for Neurorehabilitation to celebrate World Brain Day. We are proud to do that together with the World Federation of Neurology, and we hope we will have a fruitful series of discussions and presentations this afternoon. Before we start, let me briefly express my gratitude, especially to three people who helped me very much in bringing this about for today. It's Tracy Mole, our executive secretary of the WFNR. It's, of course, also Caterina Pistarini, our secretary general, and especially our friends from Romania, especially Christian and Raul, who help us technologically to bring this streaming, worldwide streaming about today. So as an introduction, I have prepared a video. Christian, you can play that for the starting.
So hello everybody and welcome to the WFNR Day on the celebration for the World Brain Day. We are proud to do that together with the World Federation of Neurology today. You know, the WFNR has three major pillars and three major elements of activity. It's to advance research, it's to advance education, and to advance clinical practice in neurorehabilitation throughout the world. And we're happy to support the intersectoral global action plan on epilepsy and other neurological disorders by the World Health Organization, and are happy that WHO is now addressing this important issue of brain health and neurological disorders. Okay, World Brain Day has several targets to address. It's, of course, all about to increase the world public's awareness on aspects of prevention, on awareness, on access, on education and advocacy in the field to combat disability in the world. And looking at the global situation, today figures show that about 1 in 3 people today around the world will have a chance to have a benefit from rehabilitation because they are living in health conditions which might benefit from that. When we look, however, at the available resources which can be devoted to this combat of disability, then, of course, the situation is very different and heterogeneous around the world. When you look, for instance, at the number of physicians per patient in different parts of the world, then you see there are tremendous differences. This certainly means that we have to make our mind up what we can do in future to find better strategies to fight against disability and increase participation and well-being of people around the globe. It's always difficult to tell something about the future. This wording has been attributed to Niels Bohr, the eminent Danish physicist, that prognosis might be difficult, especially when they refer to the future. Well, let's have a look at this. The question is, where are we? Of course, we have fortunately learned over the last 2 decades or so to conceive neurorehabilitation as an applied form of neuroscience. Neurorehabilitation, however, goes necessarily beyond this and has to incorporate social sciences up to clear political claims and strategies so that we can do the job properly. You're all familiar with this hierarchical sequence of possible intervention strategies for neurological rehabilitation on the continuum between restoration and compensation. A lot of what we're doing in rehabilitation, of course, is compensation and not really using restorative approaches in the strictest sense. When you look here at this continuum from impairment to participation or from restoration to compensation, then you can see that also depending on the amount in time when you start with the job, there may be grow differences also in the strategies and the neurobiological background about that. We certainly have critical time windows, especially after stroke, but we also have open time windows, which will eventually last forever, enabling us to do something reasonable in rehabilitation by using other strategies. So the question is, what is available, what is useful, where and when, and what is desired? We have a growing number of high-tech options available to do something in neurorehabilitation, such as robots, VR and AR and gaming technology, brain-computer interfaces, and also neuromodulation techniques. I could go on with this list. This is just a subjective short glimpse on what high-tech options are available. But even more important is that we have low-tech options, which are quite useful and really helpful, especially using strategies of learning, motor learning, and cognitive learning, and learning-based coaching strategies and procedures. The constraint-induced movement therapy is a good example of that. We also have to think more and more, and we will address quite a lot of this today on this meeting, on community-based and caregiver support options and self-training strategies. Okay, we have learned a lot from learning or applying elementary rules of motor and also of cognitive learning, such as repetition, the importance of application of feedback and knowledge of results, shaping tasks as to what the patient is just able to do, concentrate on active performance and ecological validity, and looking more and more also at the important aspect of motivation and others. Okay, probably the winner, I mentioned that already, amongst all the learning-based strategies is constraint-induced movement therapy, which has been shown in, at the moment, hundreds of studies, good and very well designed and done studies, to be efficacious in chronic and in acute problems. So, following this, World Federation of Neurorehabilitation has decided to have some important current projects this year in 2023. One is to roll out community-based education programs, and we will do that in 7 to 8 or more target areas, especially in low-middle-income countries. We try to design a representation of a complete neurorehabilitation setting in augmented reality on the metaverse, if you like, usable for education and reaching patients also from remote sites, providing assistance and teaching. And we are also running at the moment a bigger survey to look carefully at resources and future needs with involved stakeholders. On individual, local, regional, and global perspectives. Well, the combat of handicap and dealing with handicap and disability, of course, is a very important issue. Nevertheless, we have to keep in mind that prevention is even probably more desirable than curing disability problems. For this, the claim, of course, is to ensure good living conditions in terms of food, water, housing, education, healthcare, and so forth in many countries everywhere in the world. Decrease the classical risk factors for the most important disability-causing conditions affecting the brain, which is primarily, of course, stroke, traumatic brain injury, and spinal cord injuries. Increase decarbonization of energy supplies to protect the biosphere from heating and from further climate disasters. Ensure safe ways of mobility. That includes, of course, traffic protection systems, starting with helmets and other systems to reduce the risk of road traffic accidents and traumatic brain injury resulting from that. And to avoid, of course, and that is a very important issue more and more, avoid unnecessary hostility and unnecessary wars by peaceful discourses and conflict regulation. We have to keep in mind that the brain is the basis of our mental existence and probably the best thing we have. Therefore, I feel we have a responsibility to keep it as healthy as possible and to ensure our well-being, our creativity, and the future of the species in general. Therefore, we should do our best to decrease any form of disability with the means we have available, mention them, and develop even better strategies for the future. Okay, that is all I want to give as a short introduction to this day here. Just to alert you to two forthcoming bigger international events we are running. One is the European Congress of Neurorehabilitation, starting in 30th of August this year in Lyon in France, and next year in May, the 13th World Congress for Neurorehabilitation. Thank you so much.
Okay, so far for the introduction. I think we go on with that, and my delicate pleasure to introduce Stephen Lewis, who will say some words on behalf of our partners from the World Federation of Neurology. Stephen, good to have you with us here.
Thank you, Professor Holmberg. On behalf of our president, Professor Wolfgang Griswold, and the trustees of the World Federation of Neurology, it is really my privilege and honor to participate in this important webinar and discussion with the WFNR on this important day, World Brain Day, devoted to brain health and disability. I look forward to a wonderful webinar today. Thank you so much.
Thank you very much, Stephen. And then I would like to give the microphone to Professor Daphne Moragiano, who is the president of the European Federation of Neurorehabilitation Societies, and also the regional vice president for Eastern Europe and some parts of Central Asia at the moment, to share with us some ideas before we start with the community-based rehab section. Professor Daphne Moragiano has other obligations later this afternoon, so I'm happy that he will address us first, and then we go on with the program. Thank you.
Thank you very much, dear Volker. I'm very happy to see us all here under the auspices of this very important day. It's a great pleasure and honor also to work together hand in hand. I would say almost every day together with WFNR. So EFNR and WFNR are, I would say, entangled, and it's a great opportunity to support also today with my team, as we did all the time, this program. I will try immediately to share my screen. Wait a second. And to go briefly through okay, great. So now I'll do that. Great. So I hope I'm able to share my screen with you. Is it visible? Yeah, thank you very much. So I'll just to give you a brief overview regarding perspectives of developments of the European Federation of Neurorehabilitation, particularly in the frame of, I would say, special focus on Eastern Europe and Central Asia. We do believe that working together in the last years, particularly for these regions, we really may say that we have done, let's say, an excellent development in this respect. Wait a second. Okay. I have to be on the slideshow like that. Yes. So having said so, we'll concentrate as always on the four most important pillars: education, medical practice, research, advocacy, with a special focus today on education and medical practice. We are in the middle of important advocacy flow of events this year, and therefore I will touch upon also a little bit. Just want to mention that in the last 15 years, we focused tremendously on education, and we had, I would say, a very comprehensive development, 15 years putting on I would say, very consistent traditional teaching course in Europe. And then if we'll focus just on the last 2 years, what we have been able to do together in the frame of WFNR, WFNR collaboration, you will see that we had, beside our congresses, we had the chance to support the common goals of the two societies with a very consistent webinar series. I would mention these 12 editions of research webinars and 8 editions related to Jubilee, because we know we had a good chance to celebrate 25 years since we were able to get together and to do a super project, which is WFNR. We also have been able to deliver 3 important webinar series dedicated to young fellows, 2, 3 webinars, I would say 2 very focused on the really very young guys, and 1 combined with the seniors. We had a very rich Brain Awareness Week in partnership with AMN. AMN stands for Academy of Multidisciplinary Neurotraumatology in March, and we may mention that together with AMN, because we just mentioned this cooperation. We have developed with AMN a very special program, a hands-on program developed by us. It's Neurotrauma Simulation Center in Vienna. It's a program, it's a hands-on actually program dedicated to patient flow into the pathway of treating traumatic brain injuries. And we have been able to entertain all these trainings in Vienna and some other important cities in Austria, in top-notch medical and academic institutions. We had delegates from Europe, Asia, and Africa, and everybody was absolutely happy with the program. And I can tell you, we can tell you that it's a unique program in the world doing hands-on in all segments, pre-hospital, hospital, and rehab related segments of treating traumatic brain. Then recently, EFNR signed a memorandum of understanding with European Stroke Organization dedicated to education, research, guideline, and also advocacy. And we materialize this by a rich educational program that we have started. And I would mention here strategic teaching courses dedicated to dysphagia. We had the first edition in June, and we developed this in the frame of Stroke Action Plan for Europe. We had participants from Armenia, Georgia, Russia, Kyrgyzstan, Tajikistan, Kazakhstan, Azerbaijan, Uzbekistan, and Vietnam. It was a very appreciated program. We had 2 full days, also with hands-on, and we are now preparing to have a second edition with the occasion of our European Federation of Neurorehab Congress in Lyon next month in August. This will be in 29th of August. We'll have participants from almost all European countries, and I can tell you that this program is so much already appreciated by all national societies. Regarding medical practice, we have been able to deliver our first guideline 2 years ago after laborious work. Now, together with EAN and AMN, we are preparing to start working for the second important guideline. I would say first, I would say multi-domain and multidisciplinary traumatic brain injury guideline developed by these two important societies. As you will see later on, we are focusing also on a very important topic, the topic of tele-rehabilitation, particularly in the field of education, but also in the practical, from the practical perspective. As we know, currently we are facing many challenges in the field of neurorehab due to many factors that are creating, I would say, problems in our day-to-day practice. You know, the permanent aging of population, increasing prevalence of neurological disorders, and limited access to specialized care, particularly in rural and under-served areas. And tele-rehabilitation, it's really a hope, it's a good hope, and I think we can discuss a little bit later on about the impact of tele-rehabilitation in the general practice, but particularly in community-based. I'll just mention our partner societies, the most important partner societies. Happy to be here today with WFN, which is it's an important, I would say, strategic partner. And we are doing this advocacy program. You will hear today a lot about the IGAP. Sure, I will not stay too much on it, but I would rather discuss about our efforts of enlarging and developing our federation, European Federation. We had a meeting, a special meeting in Eastern Europe to embrace, I would say, all the groups around Eastern Europe that are willing to develop new societies, or at least to work in the frame of neurological societies dedicated to rehab. And we have now special programs of development in Serbia, Slovenia, Bulgaria, Moldavian Republic, Hungary, and Poland. And in this respect, we had the meeting in April with 150 participants on site and 100 online, and we really advanced the idea development. We did the same in Central Asia in June. So we may say that particularly in this region, we have been able to put together the same table, all parties interested in developing rehab in the region, from Armenia, Georgia, Russia, Kyrgyzstan, Tajikistan, Kazakhstan, Azerbaijan, Uzbekistan, and Vietnam. We had in this meeting more than 250 participants on site and 150 online, and we had this, we call it high-level meeting, networking all the groups we have here, the leaders of the delegations from each country over there. And then I would like to come slowly to the end of my presentation, mentioning that, of course, one of our main partners is European Academy of Neurology. We started absolutely new innovative program, brain health mission. Yes, we have strategic partners in this European endeavor. And just like to mention that the brain health is so important today, and we try to attack the topic from all the angles. It's important to increase awareness to all our, I would say, governments and all networks that can contribute in a way to the development of, I would say, a very stable and very reliable program in this respect. And the strategic partners that are working together with us, of course, in the initiative was initiative of this project was EAN initiative, but we are among the most important partners there. So having said so, I do believe that we can call it a good year with many developments. And also today, what we are doing today is the expression of this highly integrated work performed by us together with WFNR. Thank you very much. And this was my, I would say, WFNR special address today.
Okay, Daphne, thank you very much for doing that. You see, there's a very close interaction and an expanding field also in terms of the areas of the world which we are covering, I think, which is a very, very good and important point. The most important point is, of course, to bring all these colleagues together and make them work in the direction we would like them to do that. Okay, Katarina, some words from your side.
Thank you so much. Nice to meet you. We are very proud to be here today, and our participation to World Brain Day demonstrate how the prevention of neurological disorders and disability is a key object of our intervention, and for many international events aim to optimization the public health as a priority for policymakers. Neurological and behavioral disability is difficult to rehabilitate, and its full impact on the psychosocial life is not recognized than after the discharge of patient from hospital. And rehabilitation provide a treatment of impairment, reduce the impact of disability, and also prevent avoidable impairment. This lead our neurorehabilitation system, a complex system, but the access to quality care, when as often as needed, is critical for maintaining good health, in particular for people who experience a poor level of health. But the sentence of this day is that no one must be left behind. And for this, we are very proud to participate to this event and to organize also with the other speaker, other member of WFNR, a session on community-based rehabilitation as a developmental strategy for enhancing the quality of life for people with disability and their family. Thank you so much.
Okay, thank you, Katarina. And we start with the block on community-based rehabilitation. I mentioned that already. That is one of our major targets for this year and following years, also for the World Federation of Neurorehabilitation. Before I give the microphone to the two chairperson, Mayova Owolabi from Abidan in Nigeria and Namal Surya from Mumbai, India, I'm very happy that our first speaker is Professor Alessandro Giustini from Italy, who is one of the, let's say, first people in the world who developed and alerted people to an interest in community-based rehabilitation. So Mayova and Normal, it's on you to go on with the program now.
Thank you very much, sir, for giving us the opportunity, both me and Mayova, to organize the community-based rehabilitation webinar. We have worked together and we have made a program which will run throughout the year, and that can continue even after that. We plan to do that every 3 monthly. And what best to start with a bang on the day of World Brain Day. I have been practically busy from today afternoon, that means early morning from your place, doing the various World Brain Day program. And it indeed is a great pleasure that we take it forward through the World Federation of Neurology and WFNR, with IFNR taking a lead in various activities. Mayova, you want to say something on this beside me?
Yeah, I think today is a great day. Every day is Brain Day, because without the brain, we can't live for a second, or our life is meaningless. We are just vegetable. So we celebrate the brain every day, but today is a very special day where we bring all stakeholders together to talk about the brain and how we can make the brain function better, and even help those people who have suffered neurological injuries, brain injury, to live a productive and fruitful life. So on that note, we will be welcoming Alessandro to give the first.
Over to you, Professor Alexandro.
Yeah.
Yes, yes. I asked to Christian and I do this brief introduction on community-based by the point of view of WFNR. I am very glad and proud to be here because probably you remember some years ago in Indian World Congress, we started with some colleagues speaking around community and the role for neurorehabilitation to improve the quality and the results of community-based rehabilitation from our point of view. The focus on our point of view is inclusion and how the rehabilitation and neurorehabilitation can work for the realization of human rights and the inclusive development. Please, the second slide, Christian. This is a very brief summary of what is community-based rehabilitation. Started many years ago, but developing in the years until now. Now is a multi-sector application combining different efforts to support by education, vocational, social agencies, health services, and many different actions. And now is really visible how community is a meaning not only for developing countries, but is important mainly for neurorehabilitation to reach the goal for recovering the brain capacity that we all know how brain is the focus of the person, and the inclusion for the person pass on the brain and the brain actions for rehabilitation all over the world. The other slide, please, Christian. This is a brief summary of the international documents from different points of view, young or not so only young, and these documents have supported the developing and the change of the first idea of the community-based, arriving to now, as I explained, all over the world for developing, but not only developing countries. Christian, please, the other slide. This is the matrix of contents of community-based rehabilitation. You can see the list of health activities, but you can see all the other list of intervention and services and action. And you can see how this great matrix can and try and hope to work toward the inclusion in every condition, in every social, economical, religious, health services condition. The other slide, Christian, please. This is another brief summary, and the focus is what is the community-based inclusive development. And we have to understand, and we know, obviously, but it's necessary to underline that community-based is working, as I have said, to the inclusion, and rehabilitation is a part of his activity. And neurorehabilitation is a strong and very important part in this activity, and the name in which we can summarize inclusion and goals for community-based and probably for every time for rehabilitation is habilitation of the person with special needs. And this is a way in which neurorehabilitation and WFNR are strongly working and innovating their ideas on scientific, on research, and on clinical actions. I ask to Christian to go to the other slide, please. Habilitation and the community-based rehabilitation aims to recognize and to respond as possible in different countries the unmet needs for person with special needs by rehabilitation and by many other intervention and services, as you have seen in the CDR matrix. The other slide, please, Christian. This is only one among many other examples of a community-based project. And the focus of this project, as you can read, is based on providing training, support tools, and coaching to family, to parents, to the community, to support person, in this case, cerebral palsy, as you can see, to treat the problem, but also to accompany the person and his or her family to the possibility for a good life in the community. The other slide, Christian, please. This is a way to show in a brief and synthetic scheme how community-based can work with local community, with family, and using home care when the distance from the specialized services, from the neurorehabilitation hospital or centers. But in this point, I have to underline what Muresano said. Telemedicine, telerehabilitation is a very, very important tool for this work and to support in neurorehabilitation in the community, how we can support the quality and the efficacy of community-based intervention in distance, in rural or other local conditions. The main points is the family, as Nirmal Surya support from many years, and I agree with him. Christian, please, another example that I use every time is possible to show how is quite easy to connect community-based with specialized services in rehabilitation and mainly in neurorehabilitation. This is the methodology in Vietnam applied from some years ago. I presented together the colleagues from Vietnam in the Indian World Congress with Nirmal. And they are working and working better and better on this organization. And you can say that training, telesupport, improvement of activity day long, social and economical self-sufficiency intervention and supporting this, and training by telemedicine and the tele support can increase the quality of family activity. Every in countryside, in mountains, and non-professional operators and volunteers can create these very, very positive results. Christian, please, the other slide. And this is the last, my slide, and I am very proud to see how WFNR are increasing his work with Volker, with Daphne, with Nirmal, and with Katerina, and all the other, because I think neurorehabilitation can have more and more a good role in diffusing and increasing and qualifying activities and using funds of community-based rehabilitation, offering competencies, offering a sort of teleclinical service to the community-based rehabilitation, as that Daphne have started to present and to support. And I agree, and we can offer this idea to the foundation on the World Organization working on community-based rehabilitation, underlining the role of WFNR. Thank you all for this occasion.
Thank you very much, Alessandro. So at the end of this session, we will be taking questions. There'll be a panel discussion, which we'll be participating in. Thank you for a very brilliant and insightful presentation. So next is Nirmal Suya on family-based rehabilitation. As we know, not only was the ATTEND trial carried out in India, India has a very, very unique family system, which we intend to learn from today. Over to you, Nirmal.
Thank you, Mayowa. May I share, Christine, my slide from here? Yeah. So does my slides are visible now?
Yes, they are. Yes, we can see your slide.
Yes.
Perfect. So thank you very much. I'm going to just say in few minutes about the family-based rehabilitation. We can talk more and more about it, but you know what family is consist of. All of us know, and I don't need to explain that. But there are different kind of family. At least in India, you have the last one is joint family, which is where parents with their children, grandchildren, all of them, even the cousins, can stay together. But there can be nuclear family, single parent family, blended family, the extended family. But in India, both nuclear and the joint family is very, very common. The family system is very important because it's a set of interrelated part or subsystem. So you can see that everyone sit together, eat together. Each part serve function for wholes and support each other. They stride toward the equilibrium. So, you know, people help each other. They resist sudden changes. They have their goals and must be treated as a whole. And it is really been guided by the two things. One is the culture of the society or their family and the religion. So they follow that tradition, which goes on for years and years. So in a country like India with multi-ethnic, multilingual, multicultural, and multi-level society, family plays a role in every decision, and head of the family is the one who take all the decision in the family, what is going to happen. And I just show you, this is a very familiar and a very famous slide where one gentleman that is from the Mizoram who has 39 wives, 91 children, 33 grandchildren, 14 daughter-in-law. So there is a 181 member in family uh, in the east part of the world, and they all stay in this one house. And there's another family in Rajasthan where 185 of the people live together as a joint family. So you can see these examples which are rare to rare. So what is the family-based rehabilitation? For whom it is we are concerning? We're concerning for the people who cannot travel to rehab unit, either because of they don't have time, or the distance is too far, or the finances problem to travel. Or we can also do for people who, a patient who is very uncooperative, violent behavior, or the patient who is bedridden, or there is a family burden. So there are two people, one is working, and if she don't work or he don't work, family doesn't survive. And then old age. And who are the therapy giver? That's a big question. In family, the therapy giver can change from one person to another person, and they can shift as per availability of the time. So family member always response consists of denial, rejection, or overprotection. They always overcare the patient, and some of the members of old patient neglect the patient, particularly those who are old, and they may still suffer from the disease and they may be neglected. The care of patient is affected as there are many members which might have different attitude toward the patient. Hygiene is a major problem. A room in which patient is kept might cause a hindrance for the family member, causing neglect. And all this influence the personality of the patient and affects the emotional component of patient. So at one time, family is very big support, but at other time, if there's a huge family, small place to live, there can be issues which can cause more problem. And there can be psychosocial problem. Such patient may have a drastic change in lifestyle. Sometimes they are unable to communicate, perceive, particularly their bladder, bowel, or sexual function. Because a place like Mumbai, where is a small 6 by 6 room, 10 people, 12 people are staying, there are many other problems which can come, which may be behavior and cognitive issue. Now, family isn't an important thing. It is everything, as Michael J. Fox says. So you have shared understanding so that everyone understands what is going on. At the same time, there's a shared responsibility. Rehabilitation doesn't only involve one person, but it's a joint effort. And there is an improved outcome because the best outcome are obtained when clients have family member who take an active role. So that's something which is very interesting. There is a strength community in the family, and you can take it as a part of community-based rehabilitation because family itself become a community if they are big enough. And you can also see that family is a first community as is the implication of rehabilitation counseling. Also, family is a proximal source of care as it is characterized by deep emotion, shared history, shared intimacy, and reciprocity. So patient belonging to, underserved population with minimum access to comprehensive inpatient and outpatient rehab services should receive the family base, and patient with low education, low socioeconomic background could also receive the family base. What are the advantages of home-based therapy? May result in greater generalization by training client in their own environment using real-world tasks, may result in greater sustainability by direct involving the caregiver, may reduce the burden on family in regard to transportation and may decrease no-show rates and may be more cost-effective. So you can have poor functional recovery, may delay recovery, poor social outcome, reduce quality of life, reduce rehabilitation treatment efficiency, increase cognitive impairment, or the increased mortality. They may affect the way patient may respond because of depression, anxiety, personality problem, compliance motivation, and there may be factors like age, personality, severity of illness, expectation about outcome, attitude of family and friend, employment status, control over environment and self. So these all are the part which has to be taken here. But what is why the family is a focal point of rehabilitation? Because it helps in early diagnosis and treatment by preventing disability. If we can train the family people, pick up the early complication. Treatment approaches on family-based system. Rehabilitation is aimed at family then patient. Stress related to disability is shared. Family unit develop skills and prepare to cope with long-term effect of neurological illness. Depression and anxiety of patient and caregiver can be reduced, and family member can switch their role as per need, particularly in developing country where there are no trained nurses, where there are caregiver has to take care and you don't get people to help you out for the therapy. Family become important point, if you can say. We already heard about the community-based rehabilitation, and there were some questions in India about the community-based rehabilitation being taking off in the community as was expected. Why it is not developed as much it was affected? Because due to the economic pressure in developing country, primary focus shifts to survival and overcoming poverty than dealing with the disability. But in India, the democracy society expect leader to take the responsibility of society. And therefore, the most work remains on paper because our leaders are busy with other work. Culture factors in local community also need to be considered in avoiding failure, and unified protocol need to be modified in developing country as per the community and their culture. So in these circumstances, will FBR more effective? Maybe. There can be places where CBR and there can be places where FBR, because CBR in rural area where communities are working under a system of Panchayati Raj in India, where Sarpanch is the head of the community and who could be a focal point for the success of CBR. Otherwise, FBR can be useful in cities, metros, where nuclear family is more important and they become part of the focal point. And therefore, a bridge between the two in Indian context, as well as many other developing countries, would decide the success of any rehabilitation program in the future. This was the article which I wrote much before the COVID, and that time I felt that tele-neuro-rehabilitation as an adjunct to family-based rehabilitation will help in improving the patient outcome as well as reduce the burden of cost of the patient on the patient, family and caregiver. And this could be a future to provide low-cost neuro rehab services in developing country. And COVID has proved that, and I think it is time that we should use the family and tele-rehabilitation as a gather to reach out to the large number of people, including in the area where there is no communication or other thing. So FBR is need of our family is the focal point of rehabilitation. Bridge between CBR and FBR is important for the success of the rehab program. And COVID has made it a point that family-based rehabilitation with using the technology that tele-rehab could be a future program, and we need to adapt, therapist needs to adapt, and so are the society. I think, thank you very much. I'll come back to this at the end of this session. Thank you.
Thank you so very much. Yeah, to give another perspective to family-based rehabilitation in the pediatric age group, I have the pleasure of inviting Professor Lucia Braga to tell us more about family-based rehabilitation, particularly for the pediatric population.
Thank you
and
very
from
much.
the umbrella that was shared, that was shown on the first few slides by Niamal, the children are the ones to be protected the most by both the mother and the father. Thank you very much. Yeah, please go on.
Rehabilitation in children. Traumatic brain injury requires lifelong rehab interventions. Acquired brain injury with onset during childhood or adolescence impacts a still developing brain. Ecological new rehab would focus on this brain, promoting better performance and development of brain connectivity. In South America, we created an approach based on the family and the individual's unique setting and potential. Over the years, this methodology has been shown to be economically viable, and produced important evidence-based results. Ecological rehab is an intervention centered on the reality of each person and can be sustained in a natural and pleasurable manner throughout life. Ecological methods of intervention, which maximize available resources, bring significant outcomes while providing widespread neurorehabilitation services. A family empowered with knowledge can help the child rehab process produce superior outcomes. To ensure effective lifelong rehab, our methodology is based on the family's participation in all stages of intervention. To get best results, we work together with the family and the child to establish short-term goals that are easy to attain and consistent with long-term goals for later life challenges and potential. Here we see a girl with TBI who was followed up over the course of 11 years in our GATE lab. Families anywhere in the world can be trained within the setting of their real lives. To design, we developed tools to help the family training process. To help the family memorize the exercise to do at home, we created more than 200 illustrations of activities for stimulating various areas, such as motor, cognitive, neuropsychological, speech, language, and communication, visual motor coordination, and activities of daily living. Each family receives an individualized manual updated regularly as their child grows and develops. These drawings are available on the SERA website and can be used by any qualified practitioners. Parents learn to do the activities within the rehab team at the center. When they are ready, they begin doing the activities at their home and community. Parents and child return to the center regularly for assessment, progress, and updates to the program. To analyze the efficacy of this approach, we conducted a randomized controlled trial comparing two groups, one treated exclusively by professionals and another within this ecological family-based approach. After 1 year of intervention, the second group, which involved the family, had better statistically significant and clinically meaningful outcomes. The results of this study also show that neither educational level nor socioeconomic status impact in the parents' learning. After training with rehab professionals, the family can return to their natural role to promote their child's motor and neuropsychological development. This study was published in Brain Injury, and the methodology is described in a book. One of the reasons that family-centered ecological intervention is more effective is that it's carried out with greater affection and is pleasurable and natural. This results in greater frequency and a more sustainable rehab process. Today, neuroimaging highlights change to the brain connectivity caused by interventions. In an fMRI follow-up at our hospital, we see the development of neuronal networks 10 months after starting the family-based intervention. Neuroplasticity due to rehab can also be observed in teenagers. For example, Fatima had a stroke that affected her left hemisphere, causing hemiplegia, aphasia, reading and writing difficulties. She has an important injury in the arcuate fasciculus tract, which is a tract that connects the Broca and Wernicke areas and is very important to speech and language and reading. She was in the family and community-based rehab program for 6 months. The intervention improved speech and reading and increased the volume of the right arcuate fasciculus. Tractography shows significant changes in the right slide before and after rehab. Throughout intervention, neuroplasticity permitted language to migrate to the right hemisphere after left side stroke so that function could resume. With a cost-effective, long-term ecological approach, we can help achieve what is everyone's right, with or without brain injury, the best life possible. Thank you.
Thank you, Professor Lucia. It was very interesting study with scientific background of fMRI as well as GTI, showing how family can play a big role in the neurorehabilitation. A wonderful study. I have a pleasure in introducing my co-chair and one person with whom we have been working for this sessions on community-based rehabilitation, Professor Mayowa Owolabi from Nigeria, who is going to speak on promoting brain health through neurorehabilitation, needs and the steps. Professor Mayowa Owolabi.
Thank you very much. Thank you so much for the opportunity. Can you see my slide?
Yes, we can see.
Excellent. Thank you very much. So we know that neurological disorders are the leading cause of disability, and 1 out of every 3 people are likely to develop neurological disorder in their lifetime. And neurological conditions are the fastest growing cause of death among all the NCDs. Stroke alone costs about $900 billion per annum globally, while dementia costs at least $1.3 trillion globally. Stroke is the second leading cause of death globally. And the neurological conditions as a burden are expected to increase by 40% in terms of the number of deaths due to neurological conditions. And that has happened in the past 30 years, and that is expected to keep happening. So little wonder that the world suddenly woke up after protracted effort by a lot of stakeholders and neurologists or neurology-related disciplines that then ignited in May 2022 the Intersectoral Global Action Plan on Epilepsy and Other Neurological Conditions, which is over a year old. And the purpose of this is to ensure prioritization and governance of neurological conditions, improve diagnosis, treatment and care, promote brain health and prevent neurological injury, and support research, innovation, and information systems, and public health approach to neurological conditions generally. Within the context of all neurological conditions, within the context of NCDs, social and commercial determinants of health, and political determinants as well, political, legal, ethical, social, anthropologic, and economic determinants, the PLEASE determinants, as well as communicable diseases and mental health across the life course, ensuring that it is integrated into the entire healthcare and social care system and covered by universal health coverage and primary health care as much as possible. And of course, in this care continuum, rehabilitation, as we can see, has a pivotal role as a pillar. And so the neurology revolution was born last year, and just yesterday, the publication by the WHO on the rehabilitation recently was launched, but also the publication on the Intersectoral Global Action Plan was also published yesterday. So brain health is a complete functioning of the brain across the entire life course to support the full physical, because we need the brain to function well for physical health, very important for positive lifestyle that will protect the heart, protect the vessels, prolong life. The brain is required for mental health. The brain is required for social health, as well as spiritual well-being and quality of life. So therefore, brain health is a complete function of the brain that supports the full range of physical, mental, social, spiritual well-being and quality of life of an individual towards attaining and maintaining the epitome of a productive and purposeful life. So therefore, brain health is not only about prevention of brain injury, it also involves protection of the brain, promotion of brain function, and indeed enhancement of brain function and improvement of brain research. So basically moving away from the concept of dementia or disease-based model to eumentia and perhaps even promentia. So global synergistic actions to improve brain health for human development. Thanks to everyone who participated in this, particularly Matilde. Brain health is central to all the SDGs. Thankfully, we are beginning to realize that the SDGs cannot be achieved without brain health, without human intelligence. And so brain health is very pivotal. To promote and protect brain health means adding years to life, adding life to years, and adding meaning to life, of course, towards self-realization and self-actualization. So, and this is where rehabilitation comes in, by extending the life, meaningful life really, of those who have suffered neurological injury, not only by adding years to their life, but by adding life to their years, and indeed adding meaning to their life. So is a whole spectrum of framework that is required to optimize brain health, including addressing brain health determinants. And perhaps we should also not just look at brain disorders, determinants of brain disorder. Perhaps we should also look at determinants of brain, proper functioning of the brain, or enhanced brain function at individual and societal levels. Perhaps we need to identify high performers, those who have contributed to human evolution, and those who are still contributing, to find out what makes their brain work in the upper 5%. Find out what those factors are and how those factors can be improved and played up in the population. Not in the sense of eugenics, but in the sense of promentia. And of course, we know that the environment is very important in the ecosystem that interacts with the brain. So learning, social connection, safety, security, physical health, all of these are required to optimize brain function and enhance well-being and improve health overall. And so there are these four pillars of the neurological quadrangle, of which rehabilitation is key and critical. And then there is the core, which is the health systems and resources, which is important in linking up all the other pillars of surveillance, prevention, promotion, treatment, and acute care to ensure the best brain health across the entire life course. Now, coming to neurorehabilitation, we know that we leverage neuroplasticity as well as adaptive mode, the psychospiritual model. We know that rehabilitation is very important. There are challenges as well as solutions that can be played up or that can be applied to improve access to rehabilitation. We know that a lot of neurological conditions do not have cures, so to speak, as of today. Perhaps in the future, there may be cures, but as of today, a lot of neurological conditions do not have cure. And so people live with these conditions for their lifetime, you know. So a lack of effective curative or disease-modifying therapies limit degree of efficacious treatment for numerous neurological disorders. So for such disorders, of course, rehabilitation becomes very important. And the overall goal of rehabilitation is to optimize the functioning of a person, to improve quality of life, and maximize the ability to live a productive and meaningful life. To add years to life, add life to years, and add meaning to life. The WHO gap aims to reduce disability associated with neurological disorders in line with the biopsychosocial approach of the WHO's international classification of functioning disability and health, which we are all familiar with. Multidisciplinary palliative care services is also important in end-of-life issues and handling deterioration in health and bereavement. So the principles and the purpose of rehabilitation are to overcome limitations in existing, services and build resilient health systems. These are the solutions really that should be applied to make rehabilitation accessible, affordable, and effective across diverse settings. So rehabilitation must be integrated into national as well as subnational health priorities, planning, financing, and evaluation. Strong multidisciplinary, contextually suitable rehabilitation workforce needs to be developed through different career paths and through establishment of schools, universities that will help generate the required number of personnel across the different disciplines. Of course, we know that interdisciplinary care is very critical for neurorehabilitation, but we can expand our concept of interdisciplinary care beyond the traditional concept of speech and language therapy, physiotherapy, psychotherapy, to include new relevant fields, including medical humanities, sports, and so on, to offer holistic care and to leverage what we otherwise know as disability paradox, which is actually a disability disparity. So the spiritual sphere is highly rated among stroke survivors, as also amongst many other people living with neurological conditions. So, and it helps to reestablish continuity of self along the path to recovery, self-discovery, and self-rejuvenation after stroke and other conditions. It is guided by a sense of purpose in life and self-determination, and is critical for internal adaptation and reprioritization of individual roles. And of course, for formulation and development and deployment of coping strategies. So this is important for neurorehabilitation. Motivational therapies and arts and creative therapies might be very important in not only ensuring that there is recovery as much as possible, but that the brain is performing optimally, creatively, cognitively, cognitively, and productively across the life course, in spite and above neurological disabilities or injury. So we've examined the different paradigms, the challenges for the different pillars for rehabilitation, as well as the solutions. For instance, inadequate rehabilitation facilities and lack of trained therapists. That's the bane in terms of the system problem, system level problem. And so to deal with this, neurological conditions needs to be prioritized, and it is important to develop local and national data collection strategies to be able to come up with registries, pragmatic guidelines. It's important to use advocacy and education to increase interest and prioritization. It's important to leverage technology solutions such as telerehabilitation to bridge gaps in access. It's important to develop and reorganize infrastructure, provide effective training for all range of health workers that are required, and implement policies to promote healthy lifestyle and prevent neurological injury. That's at the system level. At the provider level, there is inadequate number of trained personnel, particularly in LMIC. So it's important to educate and train healthcare providers, leverage technology and digital tools for training and decision support systems for acute care as well as rehabilitation, improve local data collection in registry. So we know the burden, we also know what is required in terms of the number of personnel, and use advocacy to enhance prevention and telemedicine. For patient and community level, to promote neurorehabilitation and improve brain health, is important to promote health education, including social media where appropriate, and use public figures with neurological conditions to raise awareness and help with education and community engagement. This will help to address cultural and social beliefs that might hinder use of rehabilitation services. So at the end of the day, we want those who have neurological disabilities, not only as much as possible to be able to perform their physiological needs independently, meet their safety needs, belongingness and love needs, which the family helps. We've heard about family-based rehabilitation and ecological model of rehabilitation just presented, but also meet their esteem needs and growth needs in terms of cognitive needs, aesthetic needs, self-actualization, and transcendental needs. So energy therapy may be something that may help to enhance the realization of this with motivational psychotherapy, spiritual psychotherapy, motivational artwork, and music therapy. And so musicologists, philosophy, medical humanities, ethics may all be very important. In as much as we are also trying to move on with neuroimplants, with artificial intelligence, with human brain project, with regenerative medicine, human connectome, human affectome, neurotechnologies, brain-computer interfaces. We should not also forget the other aspects of neurophilosophy, neuromusicology to ensure that the brain has and retains its power for creativity to usher man and this the Homo sapiens species to the next level. So the Chinese, not the Chinese now, but the Japanese have this concept of ikigai, which is an holistic appraisal of health, whereby the individual is able to function to realize his mission or vision in life, his passion, his profession and vocation, and is productive all around through by attaining internal coherence and balance. And the Seed of a Life model also has this model of the interaction between the different aspects of being. So thank you so much for this opportunity. I have the opportunity of also speaking on other aspects of this as I have 2 additional lectures to give on this very memorable day, which is just a symbol, it's just symbolic, because every day is Brain Day. Thank you very much.
Thank you, Professor Maiwa, for highlighting the need of the brain and its activity and how it is important to step up the neurorehabilitation. Now we have session open.
Just a moment, Normal. I was just informed that Daphne wanted to say some words on the same topic before we start the general discussion. And let me give a short advice to the audience. You are cordially invited to use the question and answer, the chat room for asking questions, so which we could funnel into the general discussion later on. So if the 2 of you allow me, we give Daphne a short time to elaborate a little bit on this.
Please go ahead.
Yes, and thank you very much for giving me the chance, because I would like to free the time slot dedicated to disability solutions worldwide, and to combine, I would say, in a very suitable way the topic of community-based with that topic dedicated to future solutions. So I hope you can see my screen.
Yes, we can.
Okay, that is great. And first of all, I'd like to mention that my presentation today has many practicalities, as together with Volker, we try to establish in a very robust way this, I would say, approach dedicated to tele-neurorehabilitation, which is important. And I believe that we can, we are able to bridge professionals and communities. I will have a special focus on Eastern Europe and Central Asia, but of course, we are doing everything what we are doing in the frame of WFNR. WFNR is dedicated to the global targets that we have defined together. This is, I believe, and I'm very happy to have the chance to work hand in hand. And this is the Volker, very important, I would say, leadership in this direction. And I would like to thank a lot Volker, and to mention that with the help of Tracy and Katerina, we are able to do progress today in communicating all these things, and also developing in this great frame aspects dedicated to the focus topics. Of course, I like to thank a lot Nirmal, Alessandro, Mayowa, and Lucia for paving the way and for the great chance of opening, I would say, nicely and defining a lot of aspects dedicated to community-based. So I believe this tele-neuro rehab has a very meaningful impact into the whole discussion today. Now I will start mentioning that you know, Eastern Europe and Central Asia face unique challenges, maybe more than Western Europe and any other well-developed territories, due to the aging population, increasing prevalence of neurological disorders, limited access to specialized care, and particularly in the rural areas, and that is a fact. Community-based rehab presents a viable solution, and of course, this has the capacity of enabling us to deliver better care closer to the home of our patients, and to avoid this terrible burden that we have. Also, we'll avoid to some extent the difficulties of the centralized healthcare facilities, and this is important in the general context. I also would like to mention that as a leading organization, WFNR and WFNR will play and would like to play a crucial role in advocating for tele-neuro rehab and community-based, and providing at the end of the day expert guidelines supporting the implementation, because this is the aim at the end, to create awareness among the decision makers. We tried, and as you will see, we have a pilot project in this respect, and this pilot project is ongoing, and it's going on in Romania, and with the help of Volker. Volker worked hand in hand with us, and he was very successful, and our government paid a lot of attention after our meetings that we had last year in Romania, and we may call it a success. Of course, we'll extend this in Eastern Europe and Central Asia as a clear pilot. So let's look a little bit into the steps for implementing this tele-neuro rehab. First of all, what we like to do is to assess the current neurorehabilitation services. And this is a fact that, and this is also, I would say, an ambition, a very ambitious goal of Volker, to have an idea on what's going on in rehab in the world, and we are fully supporting him at every step in this respect. Then I think we can do, each of us in our territory, and then we can put together this puzzle and create a better mapping of the real current states of affairs in neurorehabilitation services around the world. Then have to identify the gaps and areas for improvement, and to develop, in the third step, partnership with local health organizations, patients organization, and governmental bodies. And I like very much Mayowa presentation also, and Nirmal. They stress a lot about the need to join our efforts with the regulators, and I think that it's important. Training and capacity building, it will be the next step for healthcare professionals, and as a consequence, if we have a good body and we have good means, we may educate families, we may educate and we may train, let's say, those who are willing to deliver at the community base these services. Implementation of rehabilitation, including the community-based paradigm, is really then the important goal, and we have to deliver that. And then we need to, there is a tremendous need to see and to evaluate the effectiveness of our programs. Monitoring and evaluation, it's, I would say, final goal, and then to restart, to rethink everything, to reassess. Now, let's take it easily, step by step, but still briefly. Assessment of the current rehabilitation services. We like to do that. This is the first step in our plan, involves in this project. And what we'd like to do is to do a clear assessment in this respect, and we are now creating a survey, and this assessment will serve as the foundation of our subsequent development, giving us the chance to understand the real landscape in which we are working, and to identify areas where our efforts can be significantly improved in this respect. And these are the practical steps that we have to take in this respect. We did the pilot project for Romania, as I told you, and this is the model that we are using to assess 3 pillars: availability of services in terms of inpatients and outpatient services, specialized program, numbers of facilities, range of services, geographical distribution. Then the second block is dedicated to accessibility of services, transportation costs, waiting times, other eventual barriers, and quality services in the sense of qualification, effectiveness of our treatment, patients-related aspects, outcomes, use or not use of guidelines, and so on and so forth. This is mostly focusing on what we are doing in respect to the inpatient and even outpatients in a systematic way. And this is one super block. The other block is how we'll transfer this knowledge further on to, I would say, really down to the communities, and at the end of the day, that it's a next step. But assessing I would say all information, data, and related aspects within the frame of these 3 pillars would be our target. Then having this information in our hands, we may identify the gaps and areas for improvement, and we need to analyze it in detail, and to focus particularly on the needs of disadvantaged populations, and especially those living in remote areas. And we have to derive clear conclusions from these aspects, including lack of specialized healthcare professionals, inadequate infrastructures, barrier to access for certain populations. All these, I would say, main goals are very well listed as priorities for our, I would say, approach. Collecting this information is crucial and is very informative for future decisions. Then we have to develop partnership with, I would say, regional, local health organization, patients organization, and governmental bodies. What we have done, it's building a clear, we say, long-lasting relation with our government. We had several meetings, as I mentioned last year. Our minister had clear statements, and we have implemented strategic project in Romania. I will talk immediately about that. And this project includes neuro rehab. This is about cardiovascular and cerebrovascular disorders, new strategy in Romania. And of course, we have to work hand in hand with patients' organizations. That is important. We have developed, I would say, European organizations, very strong bonds, and within the frame of our national societies dedicated to patients, we have an excellent communication in this respect. I think the key of everything is to have good access to the decision makers, to the Ministry of Health, to the government, and then things are going well. This partnership can facilitate the sharing of everything, from resources to I would say, to knowledge, and then to look into the right and best practice. A major point would be to implement a comprehensive program regarding training and capacity building for healthcare professionals, and increasing this capacity will offer us the chance, and creating networks down to the communities will offer us a very good chance to develop, I would say, knowledgeable groups and good examples how this, I would say, information, data, and knowledge can be transferred down to the people, down to the families. And of course, WFNR, working hand in hand with WFNR, can play a crucial role in this process. And we have, let's say, put together, I would say, these tracks, which are important tracks, developing training and programs, and we are doing already this. We are able to create modules of hands-on practice. As I mentioned, we have these modules working with specialty societies. We'll see down there in the fourth column, it's the partnership with special societies, and as we have developed nicely this with ISO and WSO, we as WFNR and EFNR, we have a good advantage in this respect. So the first pillar dedicated to developing training and progress from basics of tele rehab, delivering care remotely, case studies, role playing exercise, and hands-on practice is very important. I mentioned today the dysphagia modules, and we are able to develop further on many other modules that at the end of the day should be integrated. Then providing resources and materials as manuals, tutorials, webinars, research articles will be valuable. Workshops and conferences, it's clear. Partnership is important, of course, and there are many other aspects to be mentioned. And I think this is a comprehensive plan, and we are building piece by piece this. Regarding implementation of tele-rehab, it's important to mention that these programs will leverage the power of technology to deliver neuro rehab services in these territories and in these communities which might benefit. Of course, we need to construct a very solid channel and the knowledge of those who are teaching the population which will benefit. And tele-rehab offers special, unique benefits. And just to give you some examples, we may overcome the transportation elements, and so therefore we may overcome the geographical barriers. We may increase service availability by healthcare providers that may see more patients in a day, flexibility, more convenient appointments and scheduling, community of care, of course, that it's at the end of the circle, highly beneficial for long-term rehabilitation. And of course, we have also this cost effectiveness, good profile, by eliminating many, I would say, intermediate steps like travel costs for patients and so on and so on. Then we have to monitor and to evaluate our programs. And we have developed, and you will see, time is short now, but I'm sure with the immediate next occasion, we'll discuss a little bit about this KPI, quantitative measures and qualitative measures, and we'll come across these topics. So, regarding, and I close my presentation with this case study from Romania. And what we have here is the national strategy for cardiovascular and cerebrovascular diseases. And this strategy aims to reduce the burden of these diseases. It's essentially it's a combination of prevention, early detection, and the goal is to improve therapies in all respects. And WFNR and EFNR has provided expert guidance, and we organized the first national forum for this goal, for this topic, and we'll do it further on. Of course, we have convinced our government, and that it's important, that I think we have to do it also in Europe largely, and to try whatever, and they offer us a good share from this funding, which is Romanian Recovery and Resilience Plan, for further developments of tele-neuro rehab, telemedicine generally, because we are promoting telemedicine, and within the frame of telemedicine, we like to squeeze as much as possible neuro rehab. So there is a clear definition on what should be and how should be developed: pay, technology, skills, data transmission, information safety, documentation, archiving, and some other well-defined aspects. As a conclusion, we do believe that in the frame of EFNR, WFNR, we remain committed to supporting these initiatives, to supporting tele-rehab, and supporting all the concepts in the frame of implementing tele-neuro rehab, say, the overarching effect that should be detected of increasing our capacity to deliver rehab down there to the people where in any case it will be tremendously difficult to get. It will be very difficult. So I believe that this is our credo, and we are doing steps towards this important. So thank you very much, and I think
thank you.
My message to you.
Thank you, Professor Duffin. I think tele-rehabilitation is a very, very important tool which is going to be part of neuro-rehabilitation, and you have rightly pointed out, and your pilot study is definitely going to be wonderful with excellent result. So if we have some questions on the panel, Maiwa, there are 2 or 3 questions. Can we take them? Professor Volker, can we take the session is open?
I think we should allow us for 5. We are a little bit behind schedule, as usual. Doesn't take me wonder, because there's a lot of information. We should have about 10 minutes of general discussion and making points, and then we can probably proceed to that.
Fantastic.
go ahead. May I start eventually? Take the privilege.
Yes.
Of starting.
Yes, sir.
I think we learned quite a lot about the enormous plethora of problems and ideas which are arising from the idea of family or community-based rehabilitation. I think what we have to keep in mind, however, is that hundreds of millions of people in the world will never have access to that what we generally think is decent neurologic rehabilitation in the way we have done that for many, many years. I think we have done that especially in Western developed countries. We're starting to do that also in low middle income countries. But nevertheless, this general, let's say, procedures of rehabilitation will probably not be sufficient to serve in near future hundreds of millions of people in the world who need rehabilitation. Therefore, if there, I mentioned, as you know, I mentioned that several times, if there was anything good we've learned throughout this COVID-19 pandemic, then it was that our ease in dealing with, let's say, remote techniques and digital techniques has improved very much. And I would foresee that that is a little bit more than just tele rehabilitation. It's also tele education, and it's reaching communities and families and decision making by digital means. And I think that is a very important issue which we should keep in mind. Even if people do not have access to sufficient resources in terms of water, and they have sufficient resources to digital technologies more and more around the world. And I think we have to keep this in mind.
Thank you so very much for the giving us the overview on the session. And I think I have two questions from Ole. And one is to Maiva, or we can ask Lucia, anybody can give, or Alessandro. Multidisciplinary team approach is critical to effective rehabilitation for people with neurological disorder. To what extent has collaborative goal setting been implemented in this paradigm? Either Alessandro or Maiva, you can answer.
Okay, so I think the first thing that happens when a patient with neurological disability presents is to have a full assessment of a full neurological assessment. So identify what the deficits are, what the impairments are, and once that is done, not only by the neurologists of the patient, but also in the with support of the caregiver. Because in some instances, the patient may have a facial communication issue, so you need to assess the patient within the context of the family or the caregiver. Once that is done and you've identified a full range of deficits, then of course therapists have to be involved to also assess the full range of deficits within their discipline. For instance, physiotherapists for motor disability, hand use disability, same thing with occupational therapy. Psychotherapists assessing mental function, cognitive function, speech and language therapy assessing speech function, swallow function. So once the problems are defined, then the goals can be set. And goal setting is therefore multidisciplinary, puts the patient at the top or at the peak, and as the driver as much as possible, involves the caregiver, involves the therapists to ensure that the best outcome is produced. And the goals must be SMART. As we say, they must be specific, they must be measurable, they must be time-bound. And then once the therapy is applied, also a multidisciplinary manner, there is also re-evaluation, reassessment, the goal is revised again, and so on and so forth. So really is a spiral, is a spiral of assessment, goal setting, intervention, assessment, goal setting, intervention, multidisciplinary. That gets the best results. Thank you very much.
Wonderful. So I think this first question is directed toward me. What neurological substrate can we say is responsible for effective family-based rehabilitation for people with brain lesion, example stroke? So I think it is very important that therapist and the person from the family who is going to give the therapy or who's going to be the primary care has to understand each other, that what therapy a patient require and what can be offered through the family-based rehabilitation. What we have done in our setting in India right from 2005 onward is, when a patient comes who cannot come to your rehab unit, we would make a video of the exercises planned by the PT, OT, and speech therapist. And this video, we give it to the patient. And we tell the relative to follow that. And then maybe after 1 week, we request them that, okay, you make a video of what you are doing and bring it to us whenever you are coming for the next visit. And then we view those videos, that what patient, relative, or family is giving the therapy. Is that correct or is that not correct? And we will correct that and make another program on that time and give them another program. Or if they're doing correct, we continue that and add on the further therapy onto that. So that way we have kept a repo that what we have given the program as patient, as relative has followed, they are doing it correctly. And if they are not doing it correctly, we correct them in the future session, and so that the patient is benefited. So I think it is very important, the repo form between the therapist and the patient. Also, those who are following the therapy at family, 1%, 2%, or 3%, they all are at same page, so that everything is followed. And if there's anything, that feedback come back to the therapist. So that's very important. Stroke is something which we have done during COVID time, where even the physiotherapist has not seen the patient, and on tele only we have worked on that, and they've shown a wonderful response with the help of family. So I think it is doable. We could even have the mobile apps being formed, where there can be certain exercises can be given to the patient, and the family can see those exercises and can follow. So these are some of the module. Whatever suits best to your system should be followed. I think there is one more question. Will artificial intelligence boost community-based rehabilitation? Professor Alessandro, if you are there, can you please kindly highlight on this? Professor Alessandro is not there. Oh, is there? Please unmute yourself.
Can you hear us? There was a question for you.
Professor Gastini, question for you is, will
Yes.
artificial intelligence boost community-based rehab?
My comments is not a question, is only to underline how is important the point of non-professional actors in community and family-based activity. So tele support can have a specific goal in this direction, because is in many places more important than to the education of professional colleagues, but is probably more important to follow and to reach our goals.
Thank you. So Lucia, one question for you, as you have an experience. Does the education of family have any effect on FBR?
Sorry, education have any effect of?
Family-based rehabilitation. Education of the family.
Okay.
So when you educate the family and the rehabilitation outcome which you had already shown.
Yeah, we have best outcomes when the family is part of the whole process, and we train these people in education. We in the past we think that maybe parents with more high-level scholarity would have best results, but the main the scholarity was not related to age and the years of scholarity are not related to the development, the cognitive or motor development of the child. And the learning process, we assessed how much the family learned. And then we saw that scholarity was not a question. We have the same treatment and the same possibility to training and to learn from and to learn for all social classes.
Thank you so very much. And the last comment from Professor Sabat Vasti. He is from Abu Dhabi. So comment, please.
All right. So thank you very much. Thank you very much for a very exciting session. There are a couple of things just from another angle. We all know that CBR is a wonderful way forward to provide good rehabilitation in right setup. Two things I just want to ask the panel. One, are there any safety network or to sort of set the safety surveillance network, so as to say, to look at any harm that might come to the patient through provision of CBR in relatively inexperienced hand? And I'm particularly focusing on issues like UTIs and aspiration pneumonia, worsening of spasticity and pain. So how do we actually do the surveillance for that? And the second, it's a kind of comment that will we be inadvertently providing a kind of cheap, safe outlet for the governments across the world to meet their commitment for Rehab 2030 from WHO?
Thank you.
First question,
I'm
first question like Professor Gastini answer, and second question Mayawat to answer.
Okay.
I repeat, it's necessary to deeply consider the wide range of community-based rehabilitation. And we have to work in different conditions all over the world. In some countries, we have no neurorehabilitation, nothing regarding the neurorehabilitation. So it's necessary to have a world or a regional subject to support and to discuss with clinical, the existing clinical centers to offer, and in the same time to offer to the existing community-based project existing in this land, in this country, to connect contents that we know and experience and indication in neurorehabilitation to reach the goal in the quality and in the efficacy and effectiveness. And so it's necessary probably to work at the World Neurorehabilitation Federation or European Federation in a part of the world to promote our presence and our offers to qualify this activity in community-based, because a community-based have many projects and many funds from United Nations, from WHO, and from many private foundations all over the world. And it's necessary to enter, to try to enter, and to qualify a part regarding the neurorehabilitation and problems in neurorehabilitation, to qualify the way to spend these funds and to support this project. It's not so easy, but it's very important, and we can do, I think.
I think, Alexander, that's an important point, and what Sabat raised is also a very important issue. We are, of course, dealing with some deprofessionalization of rehabilitation, and that, of course, has inherent risks that something might eventually go astray or go wrong. And therefore, it's absolutely mandatory that we have some sort of surveillance I think that's absolutely important, especially as there are a lot of commercial companies and other providers around the world who may spoil the idea of family or community-based rehabilitation for commercial reasons. That is another major, for me, it's another major source of concern going forward with this. But we have to supervise that. And we certainly definitely need surveillance structures to ascertain, let's say, good practice also on these new, with these new media and new avenues of neuro rehab. I think we have had a good discussion. Unfortunately, forgive me, but I have to look a little bit at the time schedule. Therefore, I would suggest we will have another panel a little later on, and maybe one or the other aspect can be raised later. So in this respect, we will go on, Normal, with this of the video or the presentation contest, which was originated by the Indian Federation of Neuro Rehab. We are grateful for that. Normal, if possible, try to keep it to 20 minutes.
As short as possible.
Okay.
I will only request all of you to kindly give your marks 10 out of 10, and if you could share so that we can proceed forward. Is that screen is available? Yeah.
Well, you should clarify if we do it, if we do a voting, 1 is good and 10 is bad, or the other way around.
10 is the best and 0 is the bad.
That's right. Okay, just an
as usual.
Yeah. Yeah.
So I just give you a background in 30 seconds that we as on the World Brain Day, we opened this contest, video versus PPT contest for the brain health and disability, and how to create an awareness on the brain health and disability. We invited less than 35 years of age, working in field of the science. June 15th was the contest when open. July 15th was 10th was deadline. We extended it till 15th, and we selected the top abstract out of 80 abstract, 80 presentation which we received. We ourselves has given the marking to the top 5, but we will wait from you also. And today is the presentation from the 5 best we got. So this was the first, the brain health prevention and followed by the various aspects of the brain health, and then of course awareness. So these are the various points which they have put, and then access through the various points which are there, and of course finally the education through various points which has been written here with try it yourself with this house, and lastly the advocacy. So these were the 5 points which has been put forward: equal access to healthcare, housing, well-paid employment, education, prejudice and discrimination should not be supported, physical access, availability of program, and social solutions should be there. So that was presentation 1. You all can give the marks, which can be written in the chat box so that I can see them in the chat box. Presentation 2 is listen to the whispers, understanding early sign of most common neurodegenerative disorder. That's the PD and AD. So this about the PD, the various aspects of the PD, cardinal signs, and then warning signs, and then the cure for the PD and the common symptoms, typical appearance, Alzheimer's disease and dementia, various aspects, availability, no cure, of course, normal versus abnormal, and then risk factors, sign and symptoms. Then presentation 3 is about accessibility of brain disabled individual, refer to creating inclusive environment, products and services that cater to the needs and ability of individual with brain disabilities. Physical barrier, technological barrier, social barrier, architectural structure barrier, communicate information, policies. Assistive technology and electronic information, building modified for accessibility and designing houses, web-based services, accessibility society, cognitive accessibility and government policies. Then, of course, promoting accessibility like community mobility and theme park. They were supposed to send actually the video, but they did not record and send. So I'm presenting their slides. These were the video, which is presentation 4, and I'm just highlighting it here. Do I have to add the voice from the share, or the voice is not coming? Alexander? Christina? Christine?
Yes, you need when you share the screen to select the audio.
Yeah, share sound.
Exactly.
Okay, I'm sorry. Yeah. So there you are. Still not audible. Ayushman Bharat is launched by Mr. Modi as where the 5 lakh rupees is been covered by the government of India.
Can everybody hear? I can hear myself, but I can't hear the speaker.
Yeah, I think there's a last slide, so we move on to further. This is the last presentation.
Okay.
This is the presentation. So that's presentation 5.
We all agree that the brain is the most important organ in the human body, as it governs all sensations and responses, and thereby controls our lives. Hello, it's Sarah Shati, an SLP student at King Khalid University, Aziz Region, Kingdom of Saudi Arabia. I created this video to raise awareness about brain health and disability. So as I said previously, the brain is the most important organ of the human body. It's defined as the following. According to midline class, the brain is the control center of the nervous system, and it's responsible for thought, memory, emotion, touch, sight, and hearing. Brain health is influenced by a combination of lifestyle factors like diet, exercise, sleep, mental stimulation, and stress management. Making positive choices in these areas, especially as you age, can help maintain cognitive function and reduce the risk of dementia. Regular exercise improves blood flow to the brain and releases chemicals that help neurons connect and adapt. A healthy diet rich with fruits, vegetables, and unsaturated fats can promote brain health. Getting enough high-quality sleep helps maintain proper brain function and reduce the risk of Alzheimer and dementia. Also, challenging your brain through activities like reading, socializing, playing games, and learning helps form new neural connections and keep neurons active. We all know how bad stress is for our brains. Unmanaged stress releases hormones that can damage neurons over time. Practicing relaxation techniques and minimizing chronic stress can benefit brain health. There's a variety of disabilities that can affect the brain and nerve system. They range from neurodegenerative conditions like dementia to brain injuries, developmental disorders, and epilepsy, all impacting cognitive, motor, and sensory functions to some degree. Brain disabilities can severely impact patients' cognition, behavior, emotions, and ability to function independently, profoundly changing their lives and those of their caregivers. Here's a quote of a patient with dementia and how it affected his life. Now we're discussing treatment and prevention of brain disabilities. We all know that there are limited treatments for most brain disabilities and disorders, including medications, therapy, surgery, or making lifestyle changes. As for prevention, many brain disabilities and disorders do not have definitive prevention methods. However, maintaining a healthy lifestyle with good nutrition, exercise, limited alcohol, and avoiding head injuries may help reduce the risk. Our responsibility towards this population is support and raise awareness. In the end, we need to emphasize that mental illness is a condition, not a personal failure. We hope for those living with these conditions to have a better quality of life within a society that is more caring and responsive to their needs. Thank you for watching. We all agree that the brain.
So that's about the presentation of the five, and I can see that many has given their marks. Some has given, some has not given. So if anybody else want to give the marks, most welcome. Professor Volker, this was an initiation for World Brain Day done by IFNR. The idea is to reach out to the students working in the field of neurosciences to come out with certain ideas and how one can work out to create the more awareness on the brain day about the brain and neurological disability. I think Professor Stephen Levis is also there, and if he can have some judgment. So we have received many entries, not only from India, but also from outside India. And I must say that the last presentation was from Saudi Arabia.
Okay, Namal, do we have a consolidated list of the votes for one of the five?
I think only one person has given the voting, and what we have had about 10 people already judged out, and the according to them and according to this gentleman who has given the voting, the first winner would be the last presentation, the video fifth, the Sana from the Saudi Arabia. So if everybody agrees on that, we would declare the Sana as the winner. Stephen Levis also has agreed. So the first prize, the iPad mini, goes to the Sana, the one from Saudi Arabia. So we probably will have to, send the money rather than the iPad itself.
Agree, Nirmal. I also agree.
Okay, so we have a second winner as well.
So second winner, there are two people has voted for the first presentation, and two has voted for the fourth. So now the Stephen Levis is the final one to give the second prize. It's from WFN.
Okay. Stephen, do you want to comment on this?
Absolutely sure. I think the fourth presentation as well, I would agree, was could be second prize. Thank you. I thought they were all excellent, but I would agree with that.
Thank you, sir. So second person gets Lenovo Take Note. We would be able to do that at some ceremony. And I thank all of you to be supportive and helping me out, but particularly Professor Volker, who has taken this presentation into the WFNR webinar, bringing this important activity, which we thought would raise a lot of awareness among the young people, and the World Brain Day. Professor Stephen Levis will write a small note and send it to you if you could publish that into your Neurology Today newsletter. That will be nice. Thank you, Professor Volker. I appreciate and I thank you for giving me this opportunity. IFNR always come out with some new ideas how we can reach out to the more number of young people, and this was one of the activity which we thought might attract people. IFNR has sponsored both the iPad as well as Take Note. Thank you, sir. I appreciate it. Thank you. I hope I have finished in time.
Yeah. Thank you, Nirmal, for 3 reasons. One, for starting this initiative. Second, for staying in time. And third, for bringing up this good idea, which I think was really glorious, especially when it comes to a broader audience and raising the let's say enthusiasm about it. And that certainly helped. We will publish these 2 winners on the WFNR homepage as well as videos.
Thank you.
And thanks again for this very, very good initiative. If you allow me,
congratulations to both the winners, if they are there.
Oh yeah, our congratulations to the 2 winners, the first and the second winner, of course. We don't see them in presence, but from our side and from WFN side, I think as well, Stephen, if I may say so, our congratulations. That was really a great experience. I think we have to carry on a little bit. The next would be the talk by Matilda Leonardi on WFNR contribution to global international strategy. She cannot be with us at the moment because she had to go to another another obligation, but we have a video and we play this now.
Hello, everybody. I am Matilda Leonardi. I'm very honored today to speak during the World Brain Day, during the WFNR webinar. And I will speak about the WFNR contribution to the global international strategies. And in a sense, I would like just to frame our collaboration of the World Federation of Neurology along a certain line that comprises functioning, neurology revolution, rehabilitation 2030, and World Rehabilitation Alliance. These are some of the many possible areas in which WFNR is engaged around the world with its 44 members. We should start to speak about this, about the foundation. The foundation of our work relies on several elements. Certainly, one of them is the Convention for the Rights of People with Disability that is ratified in 2006, now already approved by more than 190 countries, in which they say that people with disability have to be able to participate in societies on equal basis with others. And also, countries are requested to identify barriers and take actions to eliminate these barriers, as well as to identify needs, take actions to meet them, so that the participation level of people around the globe is comparable to the level of the general population of a country. I would say that this is the start of our work as a WFNR, which already is a work that starts for more than 30 years, but that is rootly based on this convention. That is an international treaty to reinforce the understanding of disability as a human right and development priority. It is, in a sense, the frame for policy development for all policies and for all stakeholders, including us at the WFNR. But as we always say, people don't want just the right to work, for example, they want a job. In this sense, then, we have to also enlarge our broad definition of people with disability, because there is a lot of debates around who are people with disability, people with chronic disease, people with non-communicable disease, old people, aging people. In a sense, all these definitions, the impact on people's life, and the request, and the real request that we have to do to ourselves is, are we really considering people functioning? Because it is important defining a profile of disability and functioning, not only to treat the problems, impairment, but also to address people in relation to their lived experience in their own country. And I think that a biopsychosocial profile of functioning is the best indicator of treatment needs and service outcomes. This master for biopsychosocial model came out with the ICF, which is the International Classification of Function, Disability and Health, which has been fully endorsed by the WFNR, and it provides a comprehensive and globally accepted model to describe functioning. It is part of the WHO classification together with the ICD-11, the classification of disease, and ICHI, the International Classification of Health Intervention. The ICF is the model reference in terms of defining what is disability, which is defining, in fact, as an interaction of the health condition and the environmental factors, barriers or facilitator, that comprise physical, social, attitudinal, and political elements. In this sense, the biopsychosocial determinants of health impact also on how we look at the disease, not only in terms of the diagnosis, but in terms of the whole entire set of elements that compose it. If we also think to disability in terms of ICF, we would say that disability is a continuum ranging from low to high level of disability. And the distribution of the world population on the disability continuum, it says that most of people might have a low level of disability, and the extreme level of disability is affecting smaller part of the population. However, thinking in terms of functioning, we're able to define the different levels and the different levels of intervention. In this sense, the COVID-19 has been telling us that it is important to view health and socioeconomic factor as a mutually reinforcing element. The past years have in fact highlighted how health crises not only in a sense are biomedical phenomenon, but they are intrinsically encompassing political, social, cultural, and economic dimension. Future health governance could serve its purpose with more zeal if it started to account for the concept of syndemic. What is syndemic? It was defined for the first time in 2017, but it is a focus on biopsychosocial complex, which consists in the co-presence or sequential of disease and the social and environmental factors that promote and enhance the negative effect of the disease interaction in population. Thinking syndemic means to consider that health is not disconnected from the social environment in which people live. This is an emergent approach to health conception and clinical practice, and it's reconfiguring conventional historic understanding of disease as distinct entities in nature, separate from other diseases and independent of the social context. Rethinking health in terms of syndemic, it's thinking to health as a elements that tend to interact synergistically in various and consequential ways, having a substantial impact on the health of individuals and the whole population. So the syndemic model of health is where WFNR is entering. Why certain disease cluster, why multiple diseases go together or affect individuals or groups, which are the pathways through which they interact biologically, individuals and within population, and also the way in which the social environment, especially the condition of social inequity and injustice, contribute to disease clustering and interaction, as well to vulnerability. I think that this global context, rethinking global context in a biosocial social manner, allows also to put in place all the different elements. Concerning neurological disorders and brain health disorders, we know that we have more than 400 neurological diseases with a very high burden in all countries, in which diagnosis, treatment, and care breakthroughs alone are not sufficient. We also know this because since 2004, the WHO, with its Atlas for Resources for Neurological Disorders, has been clearly shown that the number of beds for neurological patients, and since 2004, 20 years, still we have the same problem worldwide, the number of beds for neurological patients is low, as well as the workforce for neurological rehabilitation services, and the workforce in terms of human and services is very low in neurorehabilitation, neuroradiology, and child neurorehabilitation. So the idea that the context is broad is also reinforced by epidemiological change with the aging of population and increased non-communicable disease. This recent report of the Institute for Health Metrics, Understanding Brain Health Around the World, it is also reporting the increase of neurological diseases, and the neurological conditions that are affecting are a trend that is not going to stop in the next years and is going to increase, seeing that mostly the stroke, Alzheimer, and intracerebral hemorrhage and subarachnoid hemorrhage are really increasing, as well as migraine and other disorders, impacting on the health of population enormously. Facing to this increase of disorders who are needing rehabilitation, we have also the report of the WHO, supported by the same Institute for Health Metrics, that was reporting that the need of rehabilitation are, this is a very important work that was done by Alarcos Cesia and the colleague, that is telling that the analysis, the global burden of disease study was telling us that there is a global need of rehabilitation worldwide. And this need has been increasing after COVID. So the policy context, the foundation of where WFNR works is based on several elements, including the Sustainable Development Goals, the Non-Communicable Disease Global Strategy, the baseline report of the WHO on healthy aging, as well as the need to go towards a universal health coverage that is embedded in other elements, such as the two elements that are very much affecting the international work of WFNR in the world, which are the Global Action Plan on Epilepsy and Other Neurological Disorders, the Brain Health Global Initiatives and Plans, and the Rehabilitation 2030 and the World Rehabilitation Alliance. All these elements provide the motivation. So towards our work as WFNR, we have foundation and we have motivation. As mentioned, the motivation of our work is certainly related so far in two major initiatives. One is the Intersectoral Global Action Plan on Epilepsy and Other Neurological Disorders, adopted in May 2022 by the World Health Assembly, which has a vision in which brain health is valued, promoted, and protected across life course, and in which neurological disorders are prevented, diagnosed, and treated, so as to have a higher quality of life. So reducing stigma and the impact of burden of neurological disorders, it is one of the target on which we can address our efforts. We also have a sort of guideline through the 5 strategic objectives of the Intersectoral Global Action Plan that are telling us where to go and what to do, not only as a World Federation of Neurorehabilitation, but also at national level through our member association affiliated 44 member affiliated societies that can define their own goals and objectives and also their own targets. Towards what? Well, towards brain health, which is also going to be detailed in this position paper that WHO is going to publish at the end of 2023, in which brain health is optimized and is becoming a sort of a target for global efforts and global population. Brain health defined as a state in which every individual can realize their own abilities and optimize their cognitive, emotional, psychological, and behavioral functioning to cope with life situation. It is towards the efforts also of the WFNR. So collaboration is the other point that is very relevant for our work. So we have the foundation, we have the motivation, and we have the collaboration. The WFNR is collaborating with mainly two areas of the WHO, with the WHO Disability and Rehabilitation Unit and with the WHO Brain Health Unit. These two collaborations bring us to collaborate to the different initiatives that both units are doing, that are global initiatives that can see the role of WFNR both in the area of rehabilitation with the WHO Disability and Rehabilitation Unit towards the reaching of the Rehabilitation 2030, towards, as we have heard, community-based rehabilitation programs, towards the development of the WHO Rehabilitation Competency Framework, and also in the World Rehabilitation Alliance, that is a work in progress for us. And we can work there for education, epidemiology, training, and regulation. The task force of the WFNR that is working is composed of many colleagues from all over the world that collaborate with the two units, the WHO Disability and Rehabilitation Unit and the WHO Brain Health Unit led by Tarun Dua. Today, it's a day in which all these units are very much, as we are going to see in our seminar, very much engaged in disseminating in World Brain Day the importance of collaboration. In fact, foundation, motivation, and collaboration realize themselves towards a commitment of WFNR towards global health and brain health. We have the steps to do this collaboration, which are very well defined. The Global Action Plan on Epilepsy and Other Neurological Disorders is providing us a set of elements towards we can achieve the targets. And by 2032, we are expecting to follow up. Our promises here is that we can collaborate with information about the situation of neurorehabilitation in the different countries. We can collaborate to the training of personnel, and we can collaborate towards defining pathways to respond to needs. Equally, this is with the Brain Health Unit, but equally with the WHO Disability and Rehabilitation Unit, we work towards the achievement of the 10 priority areas for action identified in the Rehabilitation 2030. We can do this as a single big federation, but also together with the other rehabilitation bodies that are combined together themselves into the World Rehabilitation Alliance. The 10 steps of the Rehabilitation 2030 are very clear. They are, first of all, trying to bring, as a recent WHO resolution has been stating, putting rehabilitation into the health sector, so as that it is a health intervention responding to the population needs. So we have very clear also with the Rehabilitation 2030, which are the different steps in which the WFNR can engage. So our work is done having solid foundation, strong motivation, great collaboration with other NGOs, patients association, other member states, national societies. And we also have clear our commitment towards achieving these global actions at global level. I thank my collaborators for working with me on this, and I thank all the colleagues of the WFNR that always with me and with together are building up a better society for a diminishing of disability due to brain conditions. So in this World Brain Day, we together with thousands of people around the world are here reinforcing our voice that the work together is possible, and together we can diminish the burden of disease towards brain health. Thank you very much.
Yeah, I think we have to thank Matilda very, very much indeed for, first of all, being the ambassador between the WFNR and the WHO for a long time already, and putting that so nicely together, also guiding us on the future work, on the activities with WHO and how far we can join in and also facilitate this future work. As Matilda cannot be with us at the moment, we will collect possible questions and put it forward to her. Are there any questions from? Oh, you're following us. So, are there questions to Matilda? We could see you. Oh, we cannot hear you then. No, you're in a car or something like this, right? A vehicle. Okay.
Sorry, I cannot speak because I don't have the mic.
You cannot speak, which is uncommon for you, to be honest. Nevertheless, let's take it like this. Thank you very much indeed. If there are questions, we will put it forward to you. So if you allow me, we can go further to the next major section of this series of discussion and webinars. And this is on disability solutions worldwide. I think probably Katarina is taking over and is guiding us a little bit through this program now. Yes. Some of this will be live, some of this will be by pre-recorded video.
Okay. Can I have my slide, Christian, please? In any case, yes, thank you. Can you see my slide? This is a second part, we can say, of the webinar addressed to the disability solution overworld for inclusion, adherence, sustainability, empowerment, advocacy, and removal of environmental barrier. All this aspect has been discussed in previous intervention. In this session, we have the participation of regional vice president of WFNR, the incoming president, Professor Namion Paik, and other member at large, Tsumi Kondo from Japan. This session is introduced by the video from Alexandra Rauch from WHO. She showed us how rehabilitation is a universal right for people with brain disorders and the WHO Rehabilitation 2030 initiative. Alexandra Rauch is a consultant of WHO and a collaborator in the Global General Health, a researcher also on the same field in the University Ludwig Maximilian in Munich in Germany. Christian, if we can start with the video of Alessandra. Okay.
Dear President, dear members of the World Federation of Neurology, dear audience. My name is Alexandra Rauch, and I'm very happy to have the opportunity to present on behalf of WHO Rehabilitation Program on this very important day, the World Brain Day 2023. And it's also my great pleasure to send best regards from Dr. Larcos Ciesa, who is unfortunately not able to join this day today, but she sends her best regards. Topic of the World Brain Day 2023, brain health and disability, leave no one behind, is absolutely important. People with brain disorders often experience long-term disabilities following limitations in functioning in an acute phase. And the specific areas that are going to be addressed in this World Brain Day event are absolutely important as well. I want to start to address the topics where rehabilitation has been specifically mentioned, the prevention and access. So rehabilitation is an essential service to people with brain disorders. And rehabilitation is a universal right. It is not limited to the few, for those who can afford it, or for those who have disability certificates. It's for all who are in need, for all to experience limitations in functioning related to health conditions. And functioning, as you know, it is not limited to only body functions, but functioning describes all our life areas, including body functions, but including being active and participate in communities, and thus relevant to all of us. And for all of us, independently, whether it's a brain disorder or any other health condition, we are at higher risk that at some time point of our life, we are in need for rehabilitation. So rehabilitation is a universal right, but also to have the opportunity to achieve the best levels in functioning is a universal right for all of us. In 2017, WHO has initiated the Rehabilitation 2030 initiative, and this is based on different aspects. First, the foundation of the Rehabilitation 2030 initiative is based, again, on three foundational principles. The first, rehabilitation is about functioning. And in addition to what I've already said about functioning, improving functioning, it's not only to improve functioning, but it's also to improve health, to prevent secondary conditions, what is unfortunately very frequent in people with brain disorders. And together with improving functioning, that means at the same time to also reduce the severity level of disability that is related to a health condition. And I would even go beyond this. If rehabilitation achieves optimal levels of functioning, it also helps to prevent poverty and isolation, because people have better functioning, have better opportunities to go back to work, to participate in communities. Secondly, everyone who needs rehabilitation receives quality services. And quality means that people with brain disorders should have access to evidence-based and essential interventions for rehabilitation that are delivered by a workforce that is equipped with the skills and the competences to deliver those interventions safely and effectively. And the third foundation principle is that rehabilitation is integrated across all service deliveries levels and along the continuum of care. And for people with brain disorders, it's so important that they have timely access to rehabilitation. As soon as they are diagnosed, they will benefit from rehabilitation in the acute phase, in the post-acute phase. And many people with brain disorders will have long-term need because they develop certain levels of disabilities. So they need to have access in the long term, and rehabilitation needs to be integrated into long-term services. Let me go back to the foundation, and now based on the foundation following, it required huge motivation in the 2030 initiative. We were not alone. We have incredible support from stakeholders around the globe. In 2017, we have agreed on 10 action steps that need to be addressed in our work. And since 2017, WHO, together with many stakeholders, have been working hard on these 10 action steps in producing evidence, in creating capacity, and in supporting countries. And I want to give you some insights into this. Producing evidence. I think one of the most important tools that we have developed is the WHO Rehabilitation Needs Estimator, because this is for the first time that we have numbers. Numbers for people living with brain disorders, and you can see a list on the right, who would benefit from rehabilitation. And as you can see, in 2019, it has been about 240 million people around the globe who would have benefited from rehabilitation. As we know, specifically in the low and middle resource context, it's often the case that a maximum of 50% have access to rehabilitation. So a lot of work needs to be done, but these numbers allow us now to raise awareness about these needs. Secondly, creating capacity. And again, huge support from stakeholders to work on products that address these different areas. And I will not go into in each of these products. As you can see, since 2017, we have been working hard. However, I want to highlight some of these. First, it is just 2 weeks that a package of interventions for rehabilitation has been launched. And there is a specific module on neurological conditions, and you can see 5 brain disorders who are included in this package of interventions for rehabilitation. And with this package, we have now information on evidence-based and essential interventions for rehabilitation, together with the required resources, human and material resources that are required to deliver the interventions. And this information will help countries to plan, to budget, and implement packages for rehabilitation into the health systems. But it has also the potential to support service providers, academics, and research in their work. I also want to again address the workforce. As said earlier, we have 2 very important products that will help to strengthen the rehabilitation workforce. First, a rehabilitation competency framework that allows countries to develop their national competency frameworks, to develop the competencies and to use this information when developing curricula for the rehabilitation workforce. That is absolutely important. And the skills required to deliver interventions for brain disorders, they are really essential. The second product on the workforce is a guide for rehabilitation workforce evaluation that guides countries to evaluate the existing workforce in their country, and based on that, to plan how to develop the rehabilitation workforce in a country. You can also see one product that targets rehabilitation in emergency, and you may wonder, why is this included here in my presentation? We have all learned during the pandemic that access to rehabilitation, that was the service that experienced the most severe disruptions during the pandemic. So people didn't have access to rehabilitation anymore. For people with brain disorders, it is so important to have immediate access to rehabilitation if they develop new conditions, to have a timely access. But also for those who live with brain disorders associated with levels of disability, it is so important that they have access throughout emergencies, throughout crises that could be such as a pandemic, but it could also be related to natural disasters or conflicts. And the policy brief on strength and rehabilitation in health emergencies provides and addresses also the need for people living with certain levels of disability. There are many more products, but you can learn more about them on our webpage. Now, supporting countries. Since 2017, we have already supported 37 countries in assessing their rehabilitation services in their country, and already 25 low and middle income countries have strategic plans how they want to address the strengthening of rehabilitation in their countries. So a lot of work has been done, but now it requires the commitment. It requires a commitment from countries that they agree on to integrate rehabilitation in their health systems. And as many of you are aware, we have achieved a huge milestone. In this year's World Health Assembly, it was for the first time that rehabilitation was part of the agenda. And it was not only part of the agenda, it ended up in a resolution on strengthening rehabilitation in health system that was signed by the members of the World Health Organization. A huge milestone that will help us incredibly to continue our work to strengthen the countries in rehabilitation and to make it possible that people with brain disorders have access to rehabilitation in the future. Let me go back to the topic of the World Brain Day, because I've not mentioned until now, awareness and advocacy. Without this, strengthening rehabilitation is difficult, and we need to raise awareness of the needs for rehabilitation in people with brain disorders. And with the rehabilitation needs estimator, we have a strong tool to raise awareness about the needs. It's also about advocacy, for access to services for people with brain disorders, whether it's prevention, treatment, or rehabilitation. WHO addresses this with the World Rehabilitation Alliance that has just been launched again 2 weeks ago. And the responsibility of the World Rehabilitation is going to be to advocate for rehabilitation and the needs for people with health conditions, and that includes, of course, people living with brain disorders. In the work on the Rehabilitation 2030 initiative and the World Rehabilitation Alliance, they go together. So the Rehabilitation Alliance will make use of the information that is gathered by Rehabilitation 2030 initiative and use it to raise awareness for the needs of people, but also for strengthening rehabilitation in countries. And again, this work will, of course, target countries so that they become more and more aware of the need for rehabilitation. And this again will help us that countries will use the tools that we are developing. And both will strongly work together to help us to strengthen access to rehabilitation for people with brain disorders in the future. I again go back to the topics of today, and I haven't addressed education until now. Education of the workforce on the need for people with brain disorders, but also on the skills, on the specific interventions from which people with brain disorders will benefit is essential. Educating families and carers of people with disability related to brain disorders is absolutely important. Still, many families help their family members, and they are important to improve functioning in people with brain disorders, even if we also need to take into account that there is a huge burden for family members if they're responsible to deliver the care. Rehabilitation plays an important role to educate and support family members on the interventions and the needs related to people with brain disorders. But of course, education is also important for societies. Societies need to learn more about people living with brain disorders, and not only about their disabilities, but also on the huge potential of those people who live with disabilities and how they can contribute to community and societies. I want to thank you again on behalf of Dr. Lakos Siesa for this opportunity to speak on this important day. I wish you an incredible agenda, and I've seen the agenda, and it will be a very, very interesting agenda with which you're going to continue. I thank you, and I wish you a lot of success with this World Brain Day. And if you're interested in our work, please get in touch with us, and please continue your important work. Thank you so much.
Thank you to Alexandra Rauch. Then, Volker, we can start with the contribution of the different regional vice presidents. The first one is Professor Lucia Braga, regional vice president for South America, and Jorge Hernandez Franco, regional vice president for Central America and the Caribbean. And I leave the floor to our intervention. And I think that Christian can share the slide.
Disability solutions in Brazil. When we talk about solutions for disability in Brazil, we must first address the vast region that the country occupies, over 3.2 million square miles, and the size of its population, 203 million. Of these people, 8 million have disabilities that require new rehabilitation. Solutions are not easy. There are many socioeconomic issues in different parts of the country. From the large metropolis like Rio de Janeiro and São Paulo, with many healthcare centers, to the remote areas in the Amazon with indigenous populations. Access is not equal. In 1988, Brazil's new constitution stated that every citizen has the right to free health care, no matter their location, education, or socioeconomic status. In 1990, the single health system called SUS was created specifically to ensure everyone would have medical care. There are two major providers of free public rehab. The first is called SEER, Specialized Rehabilitation Centers, with 279 small branches throughout Brazil. The second and older is the SERA network of hospitals, with 9 hospitals located in various parts of the country, providing care to diverse regions of Brazil, from Rio de Janeiro to the Amazon. SERA is a federally funded institution offering services 100% free of charge. It treats over 2 million patients annually and has a 700-bed capacity. One of the main solutions that you focus on is empowering the population throughout training and knowledge, involving the community, peers, and family in the rehabilitation of the individual with disabilities. This way, some of the activities can be conducted away from formal settings, integrated into the community, and if necessary, trained practitioners can provide remote support to more distant locations by phone where internet is not available. In regions that have internet, the SERA network makes ample use of telemedicine, which is very important in a country with such a large geographical area. There is no simple solution to resolving the problem with healthcare access across the world. But we can help ease the burden of this challenge faced by different populations by making healthcare free and by tailoring practices to the needs and settings of geographical groups. Studies have shown that by training patients, families, and communities, our efforts go a long way. Thank you.
Okay. We will have a general discussion.
Jorge.
And Jorge is next. Okay, yeah.
Hello, everyone. I'm going to talk to you briefly about rehabilitation in Mexico. About 1 billion people experience some kind of disability worldwide, and 80% of persons with disabilities live in developing countries. Latin America and the Caribbean have a population of over 650 million people, and 12% of this population live with some kind of disability. According to data from 2010, disability rates range from 5 to 23% in Mexico. The Mexican healthcare system is divided in two. On the left, you can see the two elements that compose the public system, which are the Social Security Institute and the Health Ministry Institute, and on the right, the private clinics, hospitals. Unfortunately, there hasn't been any communication between these institutes over the years, not even between the ones in the public area. And just an example to show you the poor foundation of the public system, there are only 250 rehabilitation facilities for the whole country. What's interesting is that after COVID-19, now all the systems are interacting and they're sharing patients, information, and equipment. So this is a very positive sign that shows that there's an opportunity after COVID-19. And regarding rehabilitation professionals, figures are low. There are only 2,250 certified rehabilitation specialists and 10,000 physiotherapists. The government is promoting education at this level and is providing scholarships. So this is another positive sign after COVID-19. Public rehabilitation facilities provide an inefficient service due to oversaturation and a lack of staff, forcing the physical therapists to provide therapy in groups instead of educating the patient and carer to do home therapy. So we need a consensus to determine the prevalence of neurologic diseases in Mexico and also to facilitate healthcare professionals in neurology access to the communities. Even though the government is aware of the community-based rehabilitation initiatives, the rehabilitation services are still provided by specialized institutions and general hospitals. And the answer to reach out to the community are the so-called basic rehabilitation units. Unfortunately, there are only 1,000 basic rehabilitation units in the whole country, and there are only 2 states with CBR activity. Unfortunately, in these basic units and general hospitals, a poor service is provided. There is a lack of use of functional scales, treatments are non-specific, with poorly defined goals, and usually no rehabilitation professional provides treatments, probably a nurse or a teacher. There's a need for developing a less fragmented and more community-oriented system of care in disability in the country. Taking these points into consideration, community-based rehabilitation should facilitate access to more specialized rehabilitation services and improve the education of persons who deliver rehabilitation interventions in the rural areas. So we should get closer to marginalized communities and incorporate them in decision-making, including their organization and knowledge. And this can be complemented with telemedicine, if possible, or with low-budget technologies. And we definitely have to make an impact, not only in the community, asking them to help us in providing the treatments for the patients, neurorehabilitation treatments, but also trying to improve the way rehabilitation is given in the rehabilitation facilities. We have to rethink the way we provide neurorehabilitation. Thank you very much.
Thank you very much for your interesting presentation of the situation in Latin America. And we can start with the second contribution from South Asia, Nirmal Surya, Regional Vice President of South Asia and Member at Large of WFNR, and Abhishek Srivastava, Member at Large of WFNR. Please, Nirmal.
Yeah. I thank you very much for the opportunity. And just I need to check my PowerPoint slide. It's there. Okay. CPR. So we are talking about the community-based rehabilitation, and I'm going to speak about CBR in India. And quickly, I will give an idea how it started. Then Abhishek will talk about one condition, that is the polio.
We can say, Nirmal, you have enlarged your slide.
It's fine. Can you see my presentation?
It's okay.
Yeah. So it's just a small introduction based on the joint position paper 2004, ILO, WHO, and UNESCO, the emergence of the concept of community-based rehabilitation. We already know about this, and we talked about it. And the process of CBR, as name implies, have had its roots in the community and has to drive sustenance and the support from the community. So CBR is how the villages, urban slum people take the responsibility of their life. So what is CBR? We already know about it, so we don't need to discuss about it, but we have to make aware about our own role and responsibility as a part of the community. We had a joint paper, position paper, which defined the CBR, and it's a strategy within general community development for the rehabilitation, equalization of opportunity, and social inclusion of all people with the disability. Now, what do we see in this picture? We see that a ship is going in the mainstream, and that's what exactly, when you are there, you see that from your boat. But if you are not in the mainstream, suppose you are in the side stream, then what you are going to see? You are going to see entirely different. And therefore, what we are talking is mainstream inclusions are, we need that these to be included, like person with disability, give equal opportunity, provide non-discriminatory environment for the growth and development. So disability programs should come, which should be in the government as mainstream, not into the side stream. And these are major object of CBR in India, which has been listed. And evolution of concept in India came with disability and rehabilitation, and then professionals, that is medical or who provide the rehab, are important. Then human rights, they have to be part of it, including social, culture, religious, economic, and political activities. Poverty is an important factor, particularly in developing country, which forms a vicious cycle of increasing the disability, and therefore Millennium Declaration and 8 Millennium Developing Goal to guide the implementation of declaration is important. Then eradicate severe poverty, hunger, achieve universal primary education, promote gender equality, and empower movement. And none of these goals can be effectively achieved without the inclusion of person with disability. So what were the inclusive communities? We need to include them, apply the policy, services in health, skill training, employment, and community life in general. These were the inclusive community. For the expecting them to change to fit in the existing arrangement was challenge. These were the basic principles of CRBR program, which are overlapping, complementary, and interdependent, and they cannot be separated from one from the another, as per the 2004 declaration. Inclusion means we have to have all kind of barrier which blocks PWD should be removed. Inclusion means disability issue in the mainstream of activity. It means all form of impairment and also convergence, that is involvement of PWD in the campaign struggle activities of press groups which are exclusively on disability issue. Then these are the participation. They need to be participate in all the activities, which means that there should be critical resources within CBR program so that they can be decision making. Sustainability, that's very important. Uh, there has to be strong link between government organization, non-government organization, DPOs and others so that CBR activity can be done. Empowerment, empowering the people with disability. Leadership role, that is also empowerment. Empowerment of women is very important so that they can get the necessary skill and can run. Basic principle would be advocacy. We already heard about it from WHO that how important it is. That advocacy uh, means self-determination, mobilization, organizing representative, creating space for the interaction and demand. And WRO itself is one part of the WHO which is part of the advocacy. Then these are the essential component of a CBR program in India, that is cover all type of PWD, multi-sectorial approach, good and effective referral system, full integration of PWD, committed and well-trained community member as service provider, gender and disability focus and balance, strike a balance between provision of service delivery and empowering the PWD family and community. Lastly, facilitate the formation and strengthening of the disabled people's movement to ensure that the right of PWD are not denied. Finally, moving toward the effective CBR program, community involvement and ownership, multi-sectorial collaboration in CBR, involvement of DPOs in the CBR, scaling up the CBR program, and CBR program to be used as an effective tool for poverty reduction and evidence-based practice. So who initiate the CBR? Community action for CBR is often initiated, at least in India, by the ministry or the NGOs. Most of the NGOs work as CBR, and they also represent from outside the community, ideally, which decide whether CBR will be part of the ongoing activity, community development activity. Components need to begin as a program for the rehabilitation. Look out for an action area where the need is apparent, community is receptive, resourceful and creative outside agency, and person with disability who need the services of an external agency as well as community for mainstream themselves in order to set themselves up as a contributor and not just recipient of the service. Challenges, a lack of understanding of the concept, rapid turnover of civil servants, acceptance of CBR as a valid intervention, financials, prioritization, poor management, planning of CBR, and interministry rivalry. So there is a lack of communication between, say, like social justice, health, and evidence-based fact not made available, lack of coordination between the government and the NGO who are working, absence of a cohort community level strategy, limited competence and capacity of decentralizing services, limited models of good practice. Social welfare department often has a weak structure at community level and government is preoccupied with basic need, do not include disability as a cross-cutting issue. So we look forward to a tomorrow where it does not sidestream people with disability, but include PWD in the mainstream as equal partner. Thank you very much.
Thank you, Nirmal.
Abhishek.
Abhishek, I have something.
I have sent the
Abhishek
bill for.
Hi, Abhishek.
Hi. Can you play my presentation, please, Rahul?
Christian? Okay.
Good evening, friends. Greetings from Mumbai. On this occasion of World Brain Day, we have to present our work on how we were able to prevent polio and its effects on persons with disability with community-based rehabilitation. As we all know, CBR, worked by WHO, has a strategy to increase the access to rehab services at community level. It is implemented to combine the efforts of people with disabilities, their families, their caregivers, their organizations, the NGOs, and every government bodies. Poliomyelitis had related complications, including post-polio paralysis. Today we'll discuss how we were able to prevent the infection with polio with community participation and rehab a person with disability because of polio with community-based rehab. It all started in US 1938 with the March of Dimes, followed by vaccines by Salk and Sabin. There was a significant reduction in polio cases in US in the mid-70s. But in global status, 1998, many patients in there across the world and in the country as well. In 1988, WHO has launched a massive campaign to eradicate polio by year 2000 from all across the world. It's the biggest public health initiative across the world. Things happening all across the world, including India. We're able to include polio vaccinations part of the universal vaccination program, led to massive spread and coverage. Still, there were significant cases. The government of India, 1995, launched massive campaigns, community participation, called as the Pulse Polio campaign. The aim is to eradicate polio by vaccinating all children under the age of 5 years, active community cooperation and participation. It's a difficult task, but all of us came together in that time. And what were the results is that we also were able to formulate a acute paralysis surveillance system. All persons or children with acute paralysis were assessed at the hospital level, clinic level, community level. Investigated samples were sent, and they were classified as polio or non-polio AFP. The big community outreach program, big part of the community, including all ambassadors from Bollywood, from sports, music industry, door-to-door campaign by CBR workers, and it gives the results. In next 10 years, the cases dropped just 64, and in 2012, WHO took India out of the list of polio-endemic countries. And the next 2 years, 2014, declared India as a polio-free country. The impact of this campaign was that we were able to prevent disability in about 5 million people all across the world. People still have polio, and they have very complicated with paralysis. So for that, Government of India, with Ministry of Health and Family Welfare, Ministry of Disability Affairs, European institution, government, organizations, NGOs came together and launched something called as Polio Camps campaign. So the massive community participation and planning. These camps are organized locally with local community NGOs, local tertiary level, local primary level hospitals. Patients were evaluated by clinical examination, underwent radiological testing, and those who required surgery underwent correction in the local hospitals by the team of doctors who went from big hospital to small hospital in the community. Post-op care in the wards, physical therapy services, provision of orthosis, calipers, all were done locally fabricated at the community level. And patient was sent home like a smalling boy who underwent surgery with the KFO, those who couldn't walk or given specialized mobility, scooters, etc. And massive camps were organized for people for mass welding people with disabilities, vocational training courses, and many NGOs participated in it. We were part of us in Jaipur in this massive campaign. So why implement CBR? Help people with their families, to address their impairment, improve functioning and independence, empower them to make informed decisions, and their quality of life. At the community level, it builds awareness of diversity in the community, foster more positive attitude, focus on local service systems, local resources, local practical solutions to problems, and it promotes these people with disabilities, local decision-making process, local governance, education, and hence better outcome. How we won? We won this big war against polio and polio paralysis with a massive campaign of community participation, community-based rehabilitation, and that is the way forward. Thank you.
Thank you for the opportunity, Katrina and Professor Wilson. Thank you.
Thank you so much. Thank you so much. We can go with Eastern Europe and Central Asia. Daphne is here?
No, I think Daphne has done that already.
It's finished, okay. Then we can, okay. He said, and now Western Europe, the intervention from Thomas Platz, I think is recorded. Thomas Platz is the regional vice president of Western Europe, chair of a special interest group on clinical pathway and education committee. And we start with this presentation.
Ladies and gentlemen, dear colleagues, support for neurodisabilities by neurorehabilitation, the Central and Western European perspective. Here are my conflict of interest statements, mainly related to research and education. Here my agenda, starting with burden of neurodisabilities, coming to stroke services in Europe and globally, fields of action, building the future of neurorehabilitation services, and concluding. Brain health is an evolving concept that's attracting increasing attention, not only in the health sector, but in societies in general. The idea is, and I think that's very important for all of us, to see and to acknowledge and to act accordingly, to see that the brain, the central nervous system, is the command center of the human body, controlling both our conscious and unconscious body functions, and actually influencing and performing, in a way, every aspect of life. And with that concept of brain health in mind, it's clear that many neurological disorders that affect the brain will lead to disability. They will affect individuals' quality of life, affect mobility, cognitive function, emotional well-being. In the European Union, neurological disorders are the third most common cause of disability and premature death, and the prevalence and burden are likely to increase with the progressive aging of the European population. Overall, we'd have 21 million disability-adjusted life years in the European Union.
Is mommy coming or not?
Disability affects not only the individual affected by neurological disease, but also will affect the family, caregivers, and society. It's very important to address and to combat neurodisabilities and to take brain health, the concept of brain health, into consideration. Now, among the neurodisabilities, stroke is a leading cause of death, and it's the third leading cause of death and disability combined worldwide. And if we look at incidence rates across the globe, we do see that they vary, and there is a lower incidence rate in high-income countries like Central and Western Europe compared to low and middle-income countries. Okay, this also tells us that stroke is at least partially a preventable disease, and that it really matters how we prevent and take care of stroke and those who are at risk. And indeed, these differences in incidence rates will translate to differences in disparity of burden of neurodisability related to stroke. But even when disability rates are lower in Europe and other high-income countries, stroke and related disabilities are to prevent it even more in Central and Western Europe. And that includes prevention, acute care, and rehabilitation that all can make a difference. What about our services in Europe and across the globe? World Stroke Organization, World Health Organization, Lancet Neurology Commission on Stroke conducted on this a survey on the status of stroke services, and it looked along 4 pillars of the stroke quadrangle: surveillance, prevention, acute care, and rehabilitation in 84 countries. Now, you see, for different regions of the world, the rates of good, acceptable, and poor stroke services vary worldwide for surveillance, prevention, acute care, and rehabilitation. And if we focus on high-income countries that include Central and Western Europe, you would see that, yes, we do have a good quality of surveillance, we do have a good quality of acute care for stroke. So that's very reassuring and needs to be sustained. But you see that the quality of prevention and the implementation of prevention is by far less than optimal. And the same holds true even for rehabilitation. So in high-income countries like Central and Western Europe, improving effective prevention and rehabilitation services are critical for reducing the burden of stroke. And we do have these 2 fields of action, being risk factor management and rehabilitation. And I'll focus on these 2 now. Leading risk factors for stroke are high systolic blood pressure, high body mass index, high fasting plasma glucose, ambient particulate matter pollution, and smoking as the 5 biggest leading risk factors. If we look into a pattern of risk factors, how they are reported for different regions, and we take Central Europe into the focus of our attention, we will see that key aspects of primary prevention should be hypertension control, dietary aspects including overweight, diabetes, sodium intake, and prevention and cessation of smoking. And effective primary prevention strategies are hence possible and are, of course, necessary. When it comes to rehabilitation, it is very clear that multidisciplinary staffing, that is medical, nursing, and therapeutic staff, including physiotherapy, occupational therapy, speech therapy, neuropsychology, social work, and a coordinated multidisciplinary team care with regular meetings, agreeing on goals together with patients, and working in concert. These are the main factors that have been shown to really improve the outcome. And compared to alternative services, such organized inpatient stroke unit care is associated with improved outcomes at the end of the scheduled follow-up medium at 1 year, so it's fairly long term. And this is requiring institutional care or requiring physical help with activities of daily living. And those outcomes had been independent of age, sex, initial stroke severity, stroke type, and duration of follow-up. So what about the building of services in neurorehabilitation to really achieve such better outcome and reduce neurodisability? Well, you would like to have a diversified stroke care approach that takes into account that people have different severities of stroke and that they need a long-term support, starting with the acute care, subacute stroke rehabilitation, going to the ambulatory and outpatient rehabilitation, and long-term sustained rehabilitation in the community. Now here a scheme how you might set up such organizational structures comprehensively, where you depend on the needs of patients with regard to their severity of impairment, with regard to the need for intensive or acute medical care. You can allocate the resources in a matched way. We start in the acute care hospital, the stroke unit or ICU, but then have very early rehabilitation, still with ICU standards, maybe if people need to be weaned from the ventilator and receiving very early new rehabilitation. Once they are stabilized, or if they had not been severely affected, they can be transferred to rehabilitation inpatient facility for those, which we call phase C, that still need physical help in everyday life. Or if they had been less affected, are already independent for basic activities of daily life, they might go to different ward or different rehabilitation service that is focusing more on training and less on medical care. But then it's very important for all of these that after the inpatient rehabilitation, there's a long-term care at home, or maybe if necessary in a residential nursing home, including outpatient rehabilitation, tele and community rehabilitation. Now, what is the status of affairs in terms of neurorehabilitation services in Central and Western Europe? It's my impression that in Central and Western Europe, we have very high level standards of acute care for stroke. But that focus is at times maybe associated with higher variability of attention for neurorehabilitation. So the availability of inpatient and outpatient neurorehabilitation facility varies across Europe. And in some places, it's just not sufficient. And I strongly feel that there is, in some societies, more focus on neurorehabilitation really needed. Another aspect after inpatient rehabilitation is the community situation. And here, frequently, that is characterized by too few rehabilitation professionals being trained in neurorehabilitation specifically and being available, and the absence of this multidisciplinary team approach that's so effective and needed in neurorehabilitation. But the continuum of care really necessitates community-based rehabilitation to happen. So we need these capacities, we need the professionals, we need the organizational structures, and that needs to be built in many places in Central and Western Europe to a higher degree than it had been so far. And education of healthcare professionals in neurorehabilitation is diverse across Europe. We are seeing more and more evidence becoming available, and there's a risk that we have an increasing gap between evidence and healthcare in neurorehabilitation. There's a need for knowledge management, active knowledge management, and to implement evidence-based practice really necessitates an academic education and qualification of healthcare professionals with the focus on neurorehabilitation. And that needs to be promoted in Central and Western Europe countries. We do have very well examples like the Netherlands or Belgium, but there are other countries like, I have to say, in Germany, where we still fall back behind of these needs. Let me briefly summarize and conclude. If we look at the current situation, we could say that the societies in Central and Western Europe need to pay more attention to brain health. It's so important for the societies, not only the individual, of course, the individual in the first place. And stroke is a leading cause of death and disability in Europe as well, and it's on the rise. Fortunately, we can say for Europe that acute care has a high degree of standards, and that needs to be sustained. On the other side, in terms of prevention and rehabilitation, the data indicates that efforts are more variable. And since stroke is preventable, risk factor management is key and needs to be improved and fostered. Rehabilitation capacities are variable in Central and Western Europe, likely not sufficient in many places, and need to be adjusted to the societal needs. Multidisciplinary, community-based rehabilitation needs to be built up. In the communities, there's a great deficit and a lack of opportunities for people with neurodisabilities to improve in many areas of Europe. And finally, the future needs highly and specifically qualified healthcare professionals, and hence a proper education system and active knowledge management for neurorehabilitation. And there again is room for improvement, at least in some areas of Europe, whereas in others, we have role models to look at and to learn from. Thank you very much. Sorry that I can't be with you today, but I'm happy to correspond with you. If you had comments or questions, please address them by email. Thank you very much.
Thank you very much. Now we have the intervention from Nam Yongpai from Korea. Nam Yongpai is the president-elect of WFNR.
Hello, my name is Nam Jong-baek. I'm a professor at Seoul National University College of Medicine and Seoul National University Bundang Hospital. I'm also the president-elect of the World Federation for Neurorehab. In this lecture, I'll be discussing disability solutions and providing a perspective from Korea. Disability is a global issue, and it is crucial to learn from different perspectives and experiences to create a more inclusive world for all individuals. The Sustainable Development Goals and the Convention on the Rights of People with Disabilities emphasize the importance of building disability disaggregated data and producing detailed statistics. According to end of 2021, the total number of registered disabled individuals in Korea was reported to be around 2.6 million, accounting for 5.1% of the total population of approximately 52 million. and represents an increase of 12,000 individuals compared to the end of 2020. Among the genders, there are 42% females and 58% males. The percentage of registered disabled individuals has consistently shown an upward trend since 2003, attributed to the expansion of services targeting the disabled individuals and increased understanding of the disability registration system. However, since 2010, the rate has been maintained at around 5%. Among the 15 disability types, physical disabilities have the highest proportion at 45.8%, but the prevalence is decreasing over time. Physical disability is followed by hearing impairment, visual impairment, and brain lesions. On the other hand, developmental disabilities such as intellectual disabilities and autism are increasing. Severe disabilities are present in 37%, while mild disabilities are present in 62%. The proportion of disabled individuals aged 65 and above continues to increase. In recent decades, Korea has implemented various policies and initiatives to promote the inclusion and participation of individuals with disabilities. These include the provision of accessible facilities, the introduction of the disability support pension, and the implementation of the personal assistance support program. The country has also established 5-year plans focusing on welfare services for persons with disabilities, aiming to create an inclusive society and promote specialized welfare services, including education and employment opportunities. Korea has aligned its disability concepts with international trends, expanding the categories to include brain lesions, autism, and various impairments such as hearing, visual, and intellectual impairments. Services are also available for elderly individuals needing assistance, with caregivers supporting around 810,000 beneficiaries in 2020. Persons with disability can access activity assistance services before the age of 65, and after turning 65, they can transition to assistance provided under the Act of Long-Term Care Insurance for the Elderly. All persons with disability in Korea either subscribe to the National Health Insurance or receive Medicaid benefits. Individuals eligible for assistance under the National Basic Living Security Act can receive medical assistance through Medical Assistance Program. The program covers a range of medical expenses, including hospitalization, outpatient treatment, prescription medications, and medical procedures. The Ministry of Employment and Labor operates hospitals for rehabilitative therapy after industrial injury, implementing return-to-work rehab program. The Korean Board of Rehab Medicine exam was established in 1983, and the number of rehab medicine doctors taking the exam has increased each year. In 2020, there were 2,235 specialists practicing rehab medicine, accounting for 2.5% of the total number of medical specialists. However, there is significant variability in the geographic distribution of rehab doctors, with most of them concentrated in the capital city. Apart from medical doctors, the professionals associated with rehab medicine include physios, OTs, prosthetics, orthotics technicians, SLPs, audiologists, braille translators, proofreaders, and sign language interpreters. Among these, physios and OTs are the only job types that require nation-managed certification and licenses. As of 2020, there were more than 70,000 registered physios and more than 18,000 registered OTs. In 2000, a qualification system for assistive devices technicians was established to ensure the manufacture and supply of high-quality orthotics and prosthetics. SLPs and audiologists were privately certified until 2012, when a certification system for speech-language rehab counselor was implemented. There were more than 1,800 social workers in the medical institutions in 2009, with 80% of them working in hospitals and higher-level institutions. This indicates that many social workers are employed in institutions providing rehab medicine services. In Korea, medical institutions providing rehab medicine services include specialized medical institutions, general hospitals with organized rehab medicine department, and hospital-based clinic focused on rehabilitation. There are a total of 80 resident training hospitals. The National Rehab Center is the only national central rehab institute in Korea. To expand public healthcare services, regional rehab hospitals were designated for 8 areas across the country. The Ministry of Health and Welfare has recently designated 98 rehab-oriented medical institutions to establish a delivery system for rehab medicine that encompasses acute care, recovery, maintenance, and integrated community care. Community-based rehab has been promoted with educational programs for administrators of CBR and the establishment of Strong Point public health centers. However, challenges remain in terms of unclear responsibilities among medical institutions, inadequate treatment standards, ineffective use of resources, unequal geographic distribution, increased length of stay, and rising medical expenses. To address these issues, a continuum of rehab medicine services need to be established, ensuring appropriate referrals for individuals with disabilities and their families. Since 1980, the Korean government has been providing assistive devices such as orthotics and prosthetics and wheelchairs to improve the daily living capacity of low-income individuals with disabilities. In 1997, assistive devices were included in the health insurance benefits and gradually expanded in implementation. Regulations regarding the designation of rehab assistive devices for the disabled were enacted in 2002. The objectives of these regulations were to expand the dissemination of rehab assistive devices and improve quality. Since 2005, cochlear implants have been covered by the National Health Insurance. We explored the various disability solutions and perspectives from Korea. It is essential for all of us to continue learning from each other and work towards a more inclusive and accessible world for individuals with disabilities. Let's continue to collaborate and make a positive difference in the lives of people with disabilities worldwide. Thank you for your kind attention.
Thank you very much. We go on. I think now there is the contribution from Itsumi Kondo, no?
Yes. That is
yes, right? Okay.
Yeah.
Japan. Okay. Okay.
It is great honor for me to have the opportunity to present the trial for disability in Japan to carry over the effect of robot exercise to usual life utilizing the difficulty map in this disability solution symposium. I have no UI for today's presentation. This is a description of disability on WHO website. We should understand that in the notion of disability, there is the interaction between individual with various pathologies, personal and environmental factors, and limited social support. So the assessment of disability must be performed considering the diversity and the nature of the target population. So I would like to set the topic of my talk today to the disability assessment in Japan. A robot exercise for upper extremity and the introduction its effect to usual life would be also the interest of many researchers in this field of the world. First of all, as I stated before, disability manifests differently in different populations. Life tasks that are difficult for people with specific disabilities may be easy for people with other disabilities. We must think of assessment methods that match the nature of the disabilities specific to the population. On the other hand, we should take in account the ability of individual and the difficulty of tasks when designing rehabilitation program. In such kind of situation, we often use rush analysis in Japan. This is a method of analysis devised in 1960 by Danish mathematician George Rush, which uses his original model. The model assumes that the probability of an individual answering an item correctly is defined by the product of the individual's ability parameter and the item's difficulty parameter. Both parameters are expressed as a scale score, and we can make item difficulty map and show the individual ability level on the map. I would like to show you an example for this in Japan. NCGG Practical ADL Scale NC Pass was developed for the purpose to detect the subtle change in ADL during the course of care provided to older adults. It also aims at easy use for the staff working in the long-term care setting, when it is also difficult to utilize the complicated evaluation tool for ADL. It consisted of easy questions and was scored with a response of yes or no, with the affiliated manual to make it easier to answer. It had 8 domains: eating, transfer, self-care, toilet, bathing, changing clothes, gait, stair climbing, and 100 items. This is item difficulty map and individual ability on it for the use of NC Pass in clinical and long-term care setting. The items with board number have been already accomplished by the patient, and the scene number has not yet performed. The items on the left side are easier tasks than right side items. The vertical line with the number of 46.7 presents this patient's ability. In the clinical or long-term care setting, We set the target on items near around the vertical line because there are feasible tasks when designing rehabilitation program. They are not too much difficult to accomplish and easy to think about the environmental factor which hinders the patient improvement. From here, I would like to introduce a robot for upper extremity exercise. The name of the robot is Lego J and was developed originally by Motorica in Israel. Before the introduction to Japan, it was modified according to the body size of Japanese people and the name was changed to Lego J. It has 17 types of training patterns and can be set range of motion, voluntary motion, and amount of load. There are 5 types of mode in this robot. On the full assistance mode, robot arm moves automatically. There are 3 automatic assistant modes. And on the initial mode, the robot arm moves when force is applied in the correct direction only during initial movement. On the step-by-step mode, the robot arm moves when force is applied in the correct direction for each period. For the trajectory assist, the robot arm moves at a slow speed and changes speed when a force is applied. At last, in the voluntary movement, the robot arm does not move automatically and the speed and direction can be changed freely. Purpose of this study is to analyze the difficulty both for robot training and functional skills in daily life. And as with its result, we create a tool, a difficulty map, that can share training goals at home and at the session with robot in order to carry over the effect of robots to usual life. The subjects of this study were the patient with hemiplegia who were hospitalized at our center or undergoing outpatient visits. Exclusion criteria were shown in this slide. We selected 9 items in a variety of modes and the style of loads in Lego J. Kind of exercise were forward reach, lateral reach, and radial reach, 3-dimension. 3 modes in automatic assistance were selected: initial load, step by step, and trajectory assist. For each of these tasks, we measure the number of trajectories in 4 minutes. Functional skills measure after paralysis, FSMAP, was developed as a scale for assessing functional skills of the paralytic upper extremity after stroke. Criterion-related validity with step and fin motor items are reported by my coworker. There are 50 items to assess functional skills in this scale. Subject score 1 point when he or she can perform that item. The functional skill for use of CAP and its sub-items are shown in this slide. We set the borderline to decide whether the subject accomplished the task or not, according to the data from 10 healthy young adults. This means if the subject performed a few number of the movements, but its count was not enough to the borderline, we judge the subject did not accomplish the task. The borderline was set at 2 SD lower than the average of 10 healthy young adults. At the same time, examine the FSMAP for the same subject. WinStep's version 4.3.2 was used this time for rash analysis. This is background of subjects. Average age was 75.4 years old and 25 male and 17 females. Distribution of FMA and FSMAPs are shown at the lower side of this slide. These are the number of motion trajectories for each task being tried in this study. Red line is the average of counts for healthy young adults. The top of the vertical bar is at the level of the average minus 2SD, and it is the borderline set in this study. The subject who was lower than this line was judged to not to accomplish the task in Goje exercise. This slide shows the difficulty maps both for functional skills tested in FSMAP and tasks in Goje. At the uppermost, item difficulty for use of cups is shown. In functional skills in use of cup, the easiest is touch the cup and the most difficult is drink the water. At the lower side of this slide is task difficulty for Reo Goje exercise. On the first line, there is a task difficulty for forward reach. Scale score for initial load and step by step was almost same. So they are overlapped on the line, and this means that these tasks are similar difficulty. This is a resulting case both for FSMAP and 9 tasks in the Goje exercise. The subject was patient after brainstem infarction. She had right hemiplegia and 89 years old. The score of FMA is 33 and the total score of SMAP was 29. Green dot on each item on the task means the patient performed them, and the red triangle means not performed. From the rash analysis, we can know the patient ability for items and tasks and is indicated with scaled score. The subject's scaled score is 52.8 and is shown as a vertical line in this difficulty map. Red dots are a little bit right side of the line are items and tasks not being performed but predicted to accomplish in near future. They are thought to be so-called short goals in current exercise session. At the same time, items in SMAP would be most feasible target in daily life on the current process of robot exercise. In conclusion, I believe that with the use of item and the task difficulty map, proper setting of functional skill and the ongoing robot exercise to achieve more independent life would be possible for the patient after stroke. In future, we should define the utility of the difficulty map both for robot exercise and functional skills. Thank you for hearing.
Thank you very much. We can go with the intervention from Feng Wayne, Regional Vice President of North America. I think it is a pre-recorded talk.
Yeah.
Christian?
It's not pre-recorded.
It's not pre-recorded. Oh, okay.
Oh.
Is here?
Is Wayne with us?
What? Where is he?
You can see him on the board. Well,
Please.
for saving time, let's go on with the.
We save the time, and we go away.
We go to the next, which is by Mayova.
Mayowa
If Wayne is coming
here.
in later,
Yes, of course.
Anyway, later on.
Yes,
Okay,
of
so
course.
we go on with our friend Mayova.
No?
Thank you very much.
Okay.
Let me share my
yeah.
screen. Yeah.
Yeah.
Can you see my screen?
Yes.
Thank you very much.
Yeah.
Good. Thank you very much. So I'll be talking about neurorehabilitation in Africa. Rehabilitation 2030, a call for action. As we know, for the Rehabilitation 2030 call for action to work, and for the objectives of the WHO Intersectoral Global Action Plan against neurological conditions to be successful, it's important to address the conundrum. What is the conundrum? The fact that more than 80% of the burden of NCDs and neurological injury resides in low and middle income countries. And less than 20% of the resources in terms of personnel and other resources required are in LMIC. So if this is not addressed, it will be almost impossible to achieve Rehabilitation 2030 and the targets and indices proposed by the WHO IGAP. And it's also important to identify the major diseases that are responsible for neurological disabilities in LMICs and other parts of the globe so that they can be targeted for disease-specific rehabilitation. So to illustrate the point, of course, I'll be speaking about Africa, which now has a population of 1.4 billion, 56 countries, including Madagascar, 47 countries in the sub-Saharan African region, and also in the WHO Afro region, and the most underdeveloped, economically underdeveloped part of the world, with almost 400 million people living on less than $1.25 a day. So again, when you look at distribution of public health spending, you will see that the Northern Hemisphere is well represented, whereas the Southern Hemisphere, all the way, apart from perhaps a little bit of Australia, is really starved of funds and resources. Again, illustrating the conundrum earlier mentioned. If you were to superimpose upon this map, the map of the burden of neurological conditions, you will see that it is big in the lower hemisphere, the Southern Hemisphere, but in the Northern Hemisphere, it's being combated. So LMICs bear most of the burden, but they have very little resources, and out-of-pocket payments are dominant. So usually when a patient is facing neurological disability, he's actually going through not only clinical or health stress, but also financial distress. So which makes it really very difficult to deal with. So addressing this would need us to use the treat perspective, improve availability and access to multidisciplinary care, that's therapies, increase the number of settings for care. And today we've been talking about supervised task sharing, teleservices, family-based rehabilitation, and so on and so forth. But they must be properly regulated. There must be rules guarding them. And an ecosystem must be established to ensure that there is multi-directional referral, and there are do's and don'ts, and there are protocols that govern use of different services in different settings. So research is very important to come up with low cost, effective, pragmatic solutions. They must still be effective. They must be safe in as much as they are affordable. Perhaps the best terminology is not even low cost, is to say affordable, effective, pragmatic solutions. And of course, it's important. Prevention is extremely important. You want to prevent complications and see if it's possible to develop locally produced assistive devices and guidelines for rehabilitation that is domesticated and contextualized. Enlightenment is extremely important because not only is the supply arm of the neurorehabilitation spectrum very low in low and middle income countries and in Africa, even the demand arm is also very weak. And so it's important for people to know that neurorehabilitation can make a difference. It's important to involve every stakeholder. Community engagement activities are important. Applied theater, social media. We need to inform, we need to inspire. We need to use digital tools in a global context and holistic context, not only just for tele-rehabilitation, but for tele-education and for every other means of engagement to ensure that people are enlightened and services are available and provided. So advocacy, this is very unique. I will say that the neurological community is lucky that neurological conditions and rehabilitation are beginning to take a center stage in WHO plan and with the support of more than 194 countries. So advocacy must continue also at regional levels, at country levels, through NGOs, and so on and so forth. Then training, part of which we're all doing right now with webinars, with workshops, curricula for postgraduate programs where WFNR can actually step in, career paths for therapists. So these are the things that are really all together, put together, almost like a panacea to deal with that conundrum if it is properly resourced and properly implemented cross-board. So the journey of neurorehabilitation in Africa, multidisciplinary setting, I would say, was supported by WFNR, Ibadan City of Firsts for multidisciplinary neurorehabilitation center in East, West, and Central Africa. And that was since 2010. And through that, we've been able to establish not only services, but also, and the range of services includes part of what we discussed today: occupational therapy, cognitive therapy, speech and language therapy, and so on and so forth, goal setting, different care settings, including home visit, telecare. But also, we've been able to raise a lot of awareness and advocacy about neurorehabilitation in the region. Many more countries are fired up and willing to get on board, and many more activities are going on. So in terms of therapy, which is the first part of the T, well, is important. Part of what helps to reduce costs is early and accurate diagnosis and appropriate interventions, which helps to mitigate and prevent complications, evidence-based therapies, medications. Then task sharing, task shifting is useful to be able to deliver the quantum of intervention that is required in terms of intensity and duration and frequency for recovery, for neuroplasticity. Now, for this to happen, we may think about these models of task sharing and task shifting, but the word of caution is that they must be regulated, must be supervised to avoid quackery in the name of task sharing and task shifting. So it must be supervised, it must be regulated, and it must be protocol driven. So it may be possible to involve the individual. For instance, through constraint-induced movement therapy, the individual is himself doing the practice, you know, and also through other modes, some therapeutic exercises, whether mental or physical, could be taught to lower staff cadre or family members, provided they are supported and supervised, because again, there is caregiver burden. So supported, supervised, regulated task sharing and task shifting could really be very useful in LMICs generally, and of course in Africa. So it's important to engage people, inform them and inspire them, but not stop with that, but also collaborate with them, educate and empower them to help them deliver the goods and the services. Now, peer mentorship is another thing, and I'm going to give some examples. Some stroke survivors have inspired others to know that they're likely to come out of the tunnel. There is light at the end of the tunnel. So again, integrated care in the continuum of prevention, surveillance, acute care, very important. Then system redesign, essential medicines. These are all very important because many patients who have neurological disability have comorbidities and they also need medications to stay well and stay alive. And this must be integrated in a coordinated manner. So appropriate setting, very important. At every point in time, there will be an appropriate setting for a particular patient. If a patient is supposed to be managed as an inpatient, one will not, of course, recommend community-based rehabilitation. A patient with comorbidities who has infections or chances of DVT or other complications or blood pressure is not regulated, for instance, will still be managed in an inpatient setting. Outpatient setting, when admission is no longer required and patients can come on outpatient basis. Again, the frequency of travel may not support sufficient intensity and frequency and duration of therapy. And so outpatient care may then be combined with family-supported or community-based or domiciliary or some form of telerehabilitation. And the settings must allow bidirectional transfer, meaning if a patient is being managed in a community-based setting and there is a reason for the patient to be readmitted, either due to any complication or a new incident or event, that should be done very quickly. So it's important to set up an ecosystem that will utilize appropriately all the different care settings as at when due in a safe, effective, as well as organized and controlled way. Now, universal health coverage is important to extend this to take care of out-of-pocket payments of the double jeopardy that patients suffering from neurological conditions face. The crisis from the health situation itself and the disability, and the financial crisis of not only direct but also indirect income loss and inability to afford care on a long term. So supervised, safe, and regulated speech therapy, physiotherapy, psychotherapy, those are things that are very useful and that we've practiced. Then informal music therapy, we've practiced this and we found that this actually has helped in the patient's first language. Many patients are bilingual, some speak English, most speak their native language. And we found that informal music therapy, those who are bilingual in their native language, assisted patients in recovering faster. So a lot of very simple drills and devices that we use to improve phonation and speech therapy, devices also to motivate and stimulate and provoke spontaneous speech, and peer mentorship. This particular book was written by one of our stroke patients, and it has been a source of inspiration to others. Well, stroke, what are the conditions that we commonly see in Africa that accounts for majority of the needs or demand for neurorehabilitation? Stroke, spondylosis, movement disorders, headache, and others. And those others include spinal cord injuries, brain injuries, other spinal cord disorders. I've had quite a number of success stories across the board. So settings could be acute care, and it really should be step care. If a patient has acute stroke, of course, at that point, some form of neurorehabilitation could be offered in the acute care setting. Then inpatient care setting, then outpatient, then community-based, then home-based, then family-based, telecare integrated. it's important to conduct RCTs and develop evidence-based guidelines to guide bidirectional transfer from one care setting to the other, and vice versa, to ensure safety, quality, and access. So all of this is an ecosystem, and they are all interrelated. So we've tried some of these in Africa, in Nigeria to be specific. Primary healthcare-based physiotherapy intervention was developed, and we found that primary healthcare-based and domiciliary rehabilitation were both effective in selected patients. Okay, I'll be very fast now. I'll finish very soon. We develop quality of life measures, and advocacy is very important. We have many countries now in Africa that are on board WFNR, more than 1,000 members. And we have other organizations we have established, which is also working with WFNR to ensure that people have access to neurorehabilitation, like the African Stroke Organization. And then training, and this has been support. Training needs to be improved upon. There are some training places for training in neurology in some countries, but most countries do not have those programs. And there are different career paths for the different therapists, which also needs to be improved upon. These are some of the activities engaged in the past, and during COVID and so on and so forth. And the upcoming later this year, the African Stroke Organization Conference, which is October 31st and November 1st, and of course the WFNR, NFNR conference, October 31st and November 1st. You are almost welcome. Ibadan is going to be playing host next week to one of the largest widely supported hypertension conference. Hypertension is one of the leading risk factors for stroke and other neurological disabilities, including dementia. And we're also targeting that. We have a talents program which is a mentorship program for training neurological specialists on the continent. And Africa will be playing host to the World Congress World Neurorehabilitation in 2028 in South Africa. So to summarize, moving forward will be through therapy, research, enlightenment, advocacy, and training. Thank you very much.
Thank you, Mayowa. The last one is Sabat Vasti from Middle East. Sabat, you are here. Sabahat.
I am, but I sent the recorded talk as well.
Good.
Okay, thank you.
That's fine, good.
Good morning, good afternoon, good evening, depending on which part of the world you are joining us from. I'm Sabat Asim, Vice President in the Gulf region for Gulf Federation for Neurorehabilitation. I'm also Director of Neurorehabilitation in the Neurological Institute of Cleveland Clinic, Abu Dhabi. I will talk to you on disability solutions related to Gulf region. The Gulf countries comprise of 6 Gulf Cooperation Council countries, as Bahrain, Kuwait, Oman, Qatar, Saudi Arabia, and United Arab Emirates. And there are 2 other countries in this region, Iraq and Yemen, who are not as yet part of the Gulf Cooperation Council. The disability prevalence in the Gulf or the MENA region is estimated. The existing data are based on projections, for example, using the World Health Organization and World Bank average prevalence rates on country census, and the figures are on the sample surveys. It kind of in the region of between 1.5 to 2 on average, higher in countries that have been war-stricken. We don't have the data from Yemen, but for the most part, it is in the region of about 2% of the population. There is legislative protection in the most countries for people with disabilities. The United Nations Convention on the Rights of Persons with Disability has been signed and ratified by most. Bahrain, Oman, Qatar, and United Arab Emirates have fully ratified it, as well as Yemen signed and ratified it, whereas Saudi Arabia and Kuwait have ratified but yet not signed. This is a Christine Sargent Disability Rights in the Middle East article, which is very informative, and I'll invite you to actually have a look at it. It says that across the Middle East, two key dynamics characterize contemporary disability rights movements: dynamism and fragility, disability activism, and the new communication platforms. Legislative interventions and capacity building reflect palpable currents of change and innovation, which are often driven by ground-up initiative, increasingly led by the disabled persons organizations. At the same time, the epidemic or pandemic of COVID-19 and a protracted crisis stemming from war, displacement, underdevelopment, and climate change pose threats to the health and the well-being across the region, with especially the grave implication for disabled persons in their movement. At national level, all GCC countries have ratified CRPD, and the ones that have developed legislatures to protect rights of disabled people and have committed to provide a support and services that they are entitled to under these laws. The implementation is not at the same pace in the region. Some countries have done more than others. United Arab Emirates has implemented most. The legislation of UAE is also very strong as it is in Saudi Arabia and Qatar. What underpins most of the movements and legislation in this region is the empowerment of people, of determination. So the reason we have changes from disability to determination is because I'm going to focus a little bit more on United Arab Emirates now. The United Arab Emirates has legislated that we will refer to people with special needs or disabilities as the determined ones. As part of its effort to bring a comprehensive community development, the UAE government launched a national policy for empowering people of determination. The policy aims to create an inclusive society for them and their families through services and facilities that accommodate their needs. The key elements of the legislatures in the UAE government is that the UAE government has decided that to assign official at every government institution that will be responsible for facilitating services for people with special needs. The official's title will be is the service officer for the determined ones. Setting up an advisory council, which will consist of federal and local government entities and members of the society who will provide their advice for achieving the goals of the national policy. The pillars of the national policy are 6. So the health and rehabilitation, this is the core principle. The government will provide a comprehensive high-quality health care as well as post-accident rehabilitation programs and health programs for this segment. It would invest more on research about special needs, hereditary and rare diseases that cause impediments. A national program will be launched for early detection and diagnosis of impairment. As part of the education, the government will provide an integrative education system in public and vocational education and adopt school curricula to cater their needs. It will also provide qualified teachers and specialists, appropriate supportive technologies and learning materials. They have also committed that in the vocational rehabilitation and employment, the government will provide a vocational rehabilitation program for people with disabilities. It will initiate supportive policies to recruit them in government and private institutions, in addition to create database of information about their needs. They have an outreach commitment. The government will implement unified criteria for buildings requirements, taking into consideration the needs of people with special needs. It is also committed to having the patient's social protection and family empowerment, and the government will ensure that federal local legislation for people with special needs are in harmony with the Convention of the Rights of Persons with Disabilities. A hotline is set up to receive any complaints related to from the people with special needs. Public life, culture, and sports is also one of the criteria, very important one. And indeed, the government of United Arab Emirates have supported this and sent their teams to Olympics, and they held a mini Olympic for disabled about a couple of years back in Abu Dhabi. And the government ensures the legislation for integration of people of special needs into various cultural, sports, and social activities through various awareness programs. As for the rehabilitation, I'm just going to expand a little bit. It's not available in all GCC countries. Oman, Yemen, and Iraq have limited availability. United Arab Emirates, Saudi Arabia, Kuwait, and Qatar have very good rehabilitation services. But these services, even within these countries, are not uniformly available across the country. Some areas are better served than others. Community rehabilitation has limited availability. In United Arab Emirates of Abu Dhabi, in United Arab Emirates, Emirates of Abu Dhabi has very well developed rehabilitation services right across the continuum, started from the acute right to the community-based level. Disability equipment is available, but as it is not locally manufactured, the cost is high and there is a tendency to overprice. This is from the website of the disability support website, and as you can see, everything is available online for people with special needs and their families. They can request a medical card, they can request for mobile healthcare services to attend to them, they can request a card to indicate that they are a person of determination, they can request a license to operate non-government care and rehabilitation centers for people with determination, register students of determination in government care and rehabilitation centers, seek recruitment for people with determination, apply for Sanad Smart Card to access services tailored for people of determination by different entities, apply for people of determination card in Abu Dhabi, which is a very sort of benevolent or a very high support system. It opens up a lot of venues and financial and physical supports to people in Abu Dhabi, request an authority to translate document into sign languages, and request for educational material to be transferred to Braille. So this is all available online, and you can make the application, or the people with determination or their families can actually pursue this through online without having to come out of their homes in hot weather. There are still limitations, I must say. The culture of secrecy and high disability still prevails. Feeling of shame and guilt is between both the patients and their families. Prejudices and bias, illiteracy, rising costs of supporting disability, corporate greed is at play. People are being sold very expensive equipment with limited utility on the promise that they will walk after years of having not being able to do so. More people are surviving with impairments, so the number of disabled people is increasing, and people with disability living longer, putting further pressure on the system. So that is in brief what we are doing in our region, and I hope I have given you some information that's useful in the context of today's debate. Thank you.
Thank you very much. Now we can conclude this part.
I know my friend Wayne has not shown up, so it's lost in North Carolina. I think we start with the general discussion now. As far as I can see, we have a couple of speakers who are waiting and who should, I think, give some brief and concise comments first before we start the general discussion.
We start with the round table or not?
No, we can start with the round table now, and I think Bahia.
We have 5 speakers.
Okay, so we start
Marta Imamura, Francesca Cecchi, Aikiki Bahia, Jorge, and Lorenza Spagnuolo. Lorenza Spagnuolo sent the video. I ask to the speaker to present herself and to have an opinion about this day, if it is the first time that they participated to this day. I have some questions for each of them, and I kindly ask them to reply. We can start with Kiki Bahia. Yeah, she's a North African name, but she works in Italy, and I leave the floor to her.
Thank you very much for this invitation. Yes, I'm from North Africa, but I've lived and worked in Italy for many years. I'm a neurologist with a PhD in neurosciences, and I work in neurorehabilitation of patients with severe acquired brain injuries. In my opinion, the World Brain Day is a valuable opportunity of exchange among different figures who work with people with brain disorders. And it's even more important considering the increase of global burden of neurological disease across the world, and knowing that this burden is expected to grow in the next decade. It's my first participation, but I'm very happy to be here. It's my first participation as invited as a speaker, but I have followed previous editions. And I think it's an important opportunity to follow these editions and to promote it. Thank you.
What are the implications of so-called the P4, predictive, preventive, personalized, and the participation medicine on rehabilitation of patients with brain injury? What is your opinion?
Patients with acquired brain injuries are characterized by a high heterogeneity, which creates challenges for developing care strategies and predicting recovery. So as clinicians, we know that there is an extreme variability in achieving rehabilitation outcomes in this population. And we know that patients with similar phenotypes in terms of demographic and clinical aspects will not necessarily have similar responses to brain damage, and that there are many other aspects that underline the ability to cope with brain injuries. So the first challenge, in my opinion, is to better characterize these endotypes by exploring all aspects, genetic, biological, structural, functional aspects, but also neurophysiological aspects. And in this context, I think that the P4 approach is producing deep changes in improving the characterization of patients with brain injuries. If we take the example of patients with disorders of consciousness, where it's possible to detect subtle signs of consciousness in these patients, also, even if they can't have behavioral responses clinically, this is possible by the use of advanced technologies, of course, such as fMRI or PET, but also by extracting from electroencephalography records features that improved the understanding of brain connectivity and neural networks, thanks to the use of artificial intelligence. This perspective, in my opinion, is very important because it's allowed to combine low-cost and accessible techniques with advanced techniques of artificial intelligence, and allows its utilization in different contexts and countries. Another implication is about prediction of reaching specific outcomes by the use of trained machine learning algorithms that combine a huge number of data of these patients with brain injury. For instance, in patients with the brain injury, we are able now to predict with a certain specific sensibility their possibility to be decannulated, or to achieve a good functional outcome. This has a direct impact in the everyday clinical practice because it's improve the communication with patients and relatives in terms of prognosis, but it also allows us to better plan the rehabilitation paths. For what concerns the implications in terms of prevention, which is the third P, that should be proactive rather than reactive in this approach. So we should identify the persons who are more likely to develop brain injuries and treat them to control the disease burden. So this can be made by spreading knowledge and education, by screening implementation to prevent and treat hypertension and obesity, for example, by promoting vaccination campaign and promoting also the prevention of traffic accidents that we know is the principal cause of traumatic brain injuries in young people. The personalization of the treatment is the direct consequence of a better characterization. So when we identify profiles of patients that are more likely to respond to specific treatment, we are able to give them the treatment that they need. I think in particular about the neuromodulation, pharmacological and non-pharmacological neuromodulation that works when specific neural networks are in good condition, are working, so we can use it specifically in those patients. Concerning the participation, which is the last P of patients in their treatment, I think that social robots, but also an empathic and motivated physiotherapist may drive the engagement and the motivation of patients during the treatment, may be involving also the caregivers. So the implications of 4P medicine in neurorehabilitation of patients with acquired brain injuries are many, and they give us a huge opportunity to treat all patients, to leave no one behind. Thank you very much.
We take care of your contribution, very helpful for this day. No one must be left behind is mean that no one with a specific disability, no specific disability must be left behind. Thank you, thank you. I would to share with the other speaker the opinion of Jorge. Jorge is the only man of this meeting, Jorge Hernandez Franco, who said before during the presentation of the situation in Caribbean and Mexico region. Jorge, you are here with us.
Yes, yes. Hi, Katerina. Hi, everyone.
Hi.
Thank you.
Hi. And you have not needed of presentation. You are an habitué of WFNR. You have been a member at large. And it is interesting to know if in the last year, and we discussed it during the presentation, the importance of new treatment in taking care of person, and what is, in your opinion, also the added value of artificial intelligence for predicting outcome in patients with brain injury, and of course which are the other advancement in the therapy of brain injury. This is for the public.
Yes, thank you. So first of all, I would like to congratulate all my colleagues for those wonderful lectures. I learned a lot. I've been listening to this since the beginning and since the start of the day, and I've learned a lot of all the views in this World Brain Day about what is neurorehabilitation. That's the big question. What is neurorehabilitation? And everyone would have an answer about that. And that is in addressing your question about new ways of treating neurorehabilitation. And when I talk about this, but I would like to address it this way. I could split it into two groups. I would say there's the group of technology, this group about new developments about robotics or virtual reality. And the other part would be drugs, for example, new developments for modifying drugs like in multiple sclerosis, like ocrelizumab or natalizumab. And also biologic elements or interventions, for example, botulinum toxin. So in regard to technology, briefly, because I know we're too short of time and shortness of time, due to in technology, there are a lot of controversies still, and there are newly developments about robotics and exoskeletons. and about treatments with combining artificial intelligence. And I guess more methodological research is needed about this. So if, as it's been mentioned before in other events, if you have, for example, a robotic device, use it. If your institution bought it, use it. It could be helpful in combination with other treatments, but you don't need it definitely, and you don't have to spend a lot of time if you were in a country like mine with low income. It's a low income country where you cannot spend some million of pesos just to buy a robotic device that will not be make a change in treatment of patients in a public institution. So we have to first find the first right candidate for using technology, for example, exoskeletons or robotic devices and virtual reality, and see how much they can help in different issues. We cannot use them for all problems in rehabilitation. For example, it could be useful at the acute stage, for example, a locomat in stroke patients or in head injured patients or in spinal patients. And on the other hand, we can use virtual reality and low budget treatments to combine treatments at home or home therapy or telerehabilitation with them. Virtual reality could be a very good tool to do that in our countries. In regard to artificial intelligence, new developments are being done, and the main, or I would say the mainstay of artificial intelligence, which it's very interesting, is that they analyze measurements on the patient, and that this could be used beautiful in combination with robotic devices. So the big mistake that has been made with technology is that with robotic devices like Locomat or Armio or all these devices, is that they reproduce the same mistake that has been done for many years, which is to repeat a movement and trying to repeat a treatment that can be provided by a physical therapist or occupational therapist, but that doesn't give you any advantage at all on a treatment. It's just repeating this and probably substituting the physical therapist by a machine. So we have to change this mistake by trying to use artificial intelligence that will provide us with problem solutions, other alternatives, motivate the patient through measurement of analyzing movements and helping the healthcare professional to provide other treatments. And also, in regard to the other group, just to make my answer short, that another very useful tool in my facility, is botulinum toxin. You can make a change in the treatment of patients by changing not only spasticity but shaping the movement, voluntary movement in patients, adapt orthotic devices, treat of sialorrhea, pain, all these possibilities with botulinum toxin, and I would say this can be also the cornerstone of many treatments to pave the way and combine them with other treatments. So I would say that's what I have to say, Katerina.
Some comment from the other participants on this intervention. Some other want to add something?
Let me briefly comment on what Jorge said. I think he's essentially right in the sense that we have to use our own intelligence to find out the proper pathways, what technology to use. I think robots can be very useful in certain parts. They're not replacing therapists, they're an add-on to that. And of course, artificial intelligence, by and large, is a decision-helping instrument if it's used in a proper way. There's a lot of discussion going on about data security and artificial intelligence and all this. I think artificial intelligence is a useful tool in the future, especially when it comes to decision-making or, let's say, delineating certain pathways. But it can also, it has some dangerous aspects in it, that's for sure as well. And at the moment, I think we cannot tell. in what direction AI is going to bring us. But I think it's by and large 90%. I think it will become a useful tool. We cannot really pinpoint to all the elements in which it may be useful or eventually harmful yet. But by and large, I think it's a promising thing to do. But you know, the problem is, and I think that is a very severe problem in neurorehabilitation, is an epistemological problem. From what knowledge we make decisions. And we, for years, decades, using evidence-based medicine. Okay, evidence-based medicine, certainly, especially in this field, is not the only source of coming to useful decisions. And what we have learned over these years is that, with few exceptions, we didn't have real game changers in the field. Right? And evidence-based medicine is sometimes just stirring the same old stew all the time. So it's not really inventive. And I think we have to be careful in this respect, epistemologically, not to preclude ourselves from eventually better ideas and a higher amount of creativity we could develop. So that is, I think it's a tough issue, which will become more prevalent in the future, which I think is very important to bring the field forward.
Yeah, of course. Comment? No. But to remain in this line, I would to say to Francesca Cecchi. Francesca, you are here?
Yes, of course. Can you hear me?
What is, yes, you wait this moment. What is the pathway from predictive algorithm to decision support tool in stroke patients? And another thing, because I am engaged on this, it is the time to have the registry of stroke or not?
Okay, thank you, Caterina, for these questions. I'm Francesca Cecchi. I'm Associate Professor of Physical and Rehabilitation Medicine at the University of Florence, and I direct the PROMISE Lab, which is a joint research lab between the university and the Fondazione Dognocchi Scientific Institute. And I'm really honored to be here as well. As the other speakers have already underlined, it's a very important meeting and a very important occasion to share thoughts about neurorehabilitation all over the world. Thanks again. Well, about your question, well, something has already been said about predictive algorithm, and the same applies to stroke rehabilitation. Of course, the potential to improve the accuracy of our functional prognosis is a very relevant issue, both for health service planning and for patients and relatives and for clinicians as well. So in the last 15 years, plenty of research has been devoted to this issue. But the first algorithms were based on traditional statistical approaches, mainly linear regression, and most of them were based on clinical routinely collected variables that could predict the rehabilitation outcome or the functional outcome at given time points from stroke. And as it has already been said, so I won't spend too much time on this, machine learning based algorithms have potential to improve the accuracy of this prognosis. Why this? It's because by machine learning, we can process simultaneously a huge amount of data and also heterogeneous data sets, like those that come from clinical assessment, but also those that come from neuroimaging and neurophysiology assessment, and also maybe, as Jorge was saying, data that come, for instance, from motion sensors. And this, of course, can potentially improve the accuracy of our profiling of patients. So, but developing the more accurate prediction of stroke rehabilitation outcomes, in my opinion, does not translate directly into the designing clinically useful decision support tools. The issue of decision support tools is something that we really need to think about. Someone has defined them as co-pilots of their rehabilitation team, and that's, I believe, is their role. I mean, we need to be careful, as Volker was saying, because the risk is that if we already have decision support tool that tells us what to do, what we risk is to follow the decision support tool because it's complicated to argue with it. So we need to put it in place and criticize it. In developing decision support tools, what I think must be underlined is that the engineer has mainly a technical role, but who needs to be involved are the rehabilitation team, including clinicians, but mostly patients and caregiver, because it's them who need to point out which are the relevant target. For instance, a patient and a family will never ask you what Bartel index will I reach at when I'm discharged. They will ask you, will I be able to walk? Will I be able to be left alone? Or will he or she be able to be left alone? These are the questions that a family asks, and clinicians also want support in those things that they have to decide. Like, for instance, which kind of treatment should I prescribe in the rehabilitation plan when many treatments are...
Francesca, after discharge.
Yes, and also after discharge. I mean, when should I discharge this person? Does he or she have still potential to recover or not? So these are the things that we should need support. Another very important thing about a decision support tool, and that's the last thing I'm going to say on this issue, is that they need to be transparent and explainable, which is almost the same thing, because I need to know how the decision, how the advice on decision has been made by the machine, which kind of variables have been considered for each patient. I mean, and I have weighted towards one decision or another, because I may also criticize it if I understand the process. But if I just get the result, then it's much more difficult to give the right weight to this tool. So it risks to be more confusing than helpful in a way. And as far as your second question, it pretty much links to the first one, because of course, to devise a registry, first of all, you need to standardize assessments. And so in a way, the registry could also be a source of information for predictive algorithms and the decision support tools. Yeah. Of course, a registry needs a substantial amount of resources and time and effort, and that's probably why we haven't got a stroke registry in Italy. But in favor of the registry, besides what we have already told, is the fact that wherever a stroke registry has been implemented, the quality of care has improved. And that's a general rule in human behavior and process. So whenever you start measuring and comparing outcomes, generally the quality improves. And another issue that I would like to mention very briefly about registries is that I like your question, stroke rehabilitation registry, because wherever national stroke registries have been implemented, they are mainly focused on either the hyperacute phase, the stroke unit, and then the stroke outcomes at given time points. And this, in my opinion, is a mistake, because as neurorehabilitators, we all believe that rehabilitation does make a difference. But if we do not trace the rehabilitation processes and we do not record rehabilitation outcomes, then we won't be able to understand whether the trajectory is a natural trajectory or whether rehabilitation has impacted it, and which kind and which setting and which timing and which interventions have actually been responsible for at least part of the final functional outcome. So I believe that keeping trace of this is very important if we actually will develop a stroke rehabilitation registry. And in Italy, we have tried as Italian Physical and Rehabilitation Medicine Society, along with the Italian Neurorehabilitation Society, we have recently published a minimal assessment protocol for persons addressing rehabilitation after a stroke that we are trying to implement throughout Italy can be improved, of course, but it could be a basis for assessing the same thing and being a core element of the future stroke rehabilitation.
But Francesca, you can see in last presentation is Angel project that you know.
Angel, yes, of course, I know it.
Yes, Angel project is an international project on stroke in the acute phase. This is a sort of registry to implement the taking care of patient in acute phase with the stroke over world. And I think that also in rehabilitation, we need some specific pillar of rehabilitation of patients, because if we have not the possibility also to implement alternative strategy and to know which patient need which type of exercise. This
I totally agree with you. Yes, there's preliminary evidence that, you know, given a subpopulation of stroke patients that have evidence-based recommendations for 2 or 3 different types of treatment, then you can sort out that the predictors of responding best to one type of rehabilitation are not the same as to another type, like for robotic compared to traditional rehabilitation. And so you should optimize treatments according to what you gain from these analysis. But first you should have a huge data sets from all over the world to make this comparison.
I think that this topic, this item is online with the question that I would to ask to Marta.
Let me briefly give a short comment on this.
Sorry.
Because I think I have to introduce some caveats in that. I think every one of us is interested in data collection, is interested in registries, which may help for structured data collection. But we have to be pretty careful when it comes to prognostic information. I think all of us are hitting on focalized, personalized, individualized medicine. But there is a severe ethical problem involved. I may say that if we do not have sufficient data and data which are appropriate, we make wrong decisions as to should this patient be treated or not. So that it's certainly necessary to introduce a little caveat on that. We are in a very early stage of coming to such a focalized medicine approach. So a little careful about it.
I totally agree with that. Maybe it wasn't clear from my presentation because I need to keep it in 5 minutes, but I believe there are many ethical concerns about the application of these decision support tools, and we should take them very carefully, especially if somebody wanted to take them as suggestion of not to treat or to stop treating.
Right.
This is very dangerous. Thank you.
Marta, nice to meet you.
Yes,
What
Catarina.
what do you think about the rehabilitation treatment? Do you believe that rehabilitation treatment in a person with brain injury is sufficiently addressed in research? And if not, why? Why not? And it is the role of multidisciplinary research is well developed in some countries, not over world, I think, and which can be improved to arrive to have a multidisciplinary contribution in research.
Thank you, Professor Katerina. Thank you, Professor Volker. It's such an honor and privilege to be participating in this World Brain Day by the World Federation Neurorehabilitation. Like Professor Francesca, I'm here since the beginning. It was a lot of learning, a lot of different perspectives. So I am Marta Imamura. I am Associate Professor of Physical Medicine and Rehabilitation at the Department of Legal Medicine, Bioethics, Labor Medicine, and Physical Medicine and Rehabilitation at the University of Sao Paulo in Brazil. So maybe, of course, there's always room for improvement, right, in every field in sciences and health, but as Professor Alexandra Roche mentioned to us, just 11 days ago, the WHO launched the package for interventions for rehabilitation. Module 2 includes neurological conditions, including brain injuries, stroke, traumatic brain injuries, but also Parkinson's, cerebral palsy. And in that document, you will see that most of the recommendations from the WHO derives from relative good quality of evidence, since nutrition, sleep, as mentioned by other speakers during this day, to pain management, etc., in this specific population. Now, what I would like to take our attention and in the important historical first ever resolution on strengthening rehabilitation in health systems, which was adopted unanimously, universally by all member states of the World Health Organization. And in this very important document, it urges member states, which means all the countries that were mentioned today, to promote high-quality rehabilitation research, including health policy and systems research, which means that now the member states or the countries are somehow obliged to provide adequate funding, adequate infrastructure, and capacity building for the rehabilitation workforce related to develop or collect data on high-quality research. And we have a big challenge that everybody should be aware of. This resolution was undertaken under #1 pillar, which is to get 1 billion more people benefiting from universal health coverage, inclusive of rehabilitation. So the research question that we should have now is how can, under all the epidemiology that was brilliantly presented by the region's countries today, how can we then think together with the artificial intelligence, but using human intelligence, knowing the status, how can we provide better care for people? And this requires somehow a shift in mindset, because we're talking about now financing rehabilitation. We're talking about selecting countries or areas where this need is most relevant, right, in a smart way. And not only services, rehabilitation, but don't forget about the provision of assistive products to our patients. And the vision is that everyone, every human being who needs rehabilitation receives quality services to optimize their functioning in everyday life. And I think Professor Alexandra also raised the attention of the World Rehabilitation Alliance. There are lots of work streams, but there is a specific research work stream that wants to, what's the aspiration of this work stream research? Is that systematic integration of health policy and systems research, high quality evidence in planning, development, implementation, and evaluation of health policies for rehabilitation. So we do have a resolution, we do have a political will and commitment to introduce quality rehabilitation in the lives of every human being. Now, we as World Federation Neurorehabilitation on any other stakeholder should be harmonized with this aspiration so that we can advocate or even conduct or demand for the utilization of this type of research that maybe we will answer the questions raised by Professor Volker, about the evidence-based medicine, but also generate high quality research that will inform policymakers. Are we doing the right thing? Are we producing the quality rehabilitation and delivering it in the proper way? And the most important, Katerina, is that now the countries will have a data set of baseline information towards universal health coverage. So I think that we should embrace this moment. We should be in the same wavelength, even intellectually, so that we can collaborate. Because sometimes we do research because it's highlight. Maybe it's time to perform research in a collaborative way. Why not multidisciplinary, multi-departmental, international, multi-center, but with objective outcomes that provides equity in care. And then just to finalize, because I still have 10 seconds, maybe think also in our mindset, the translation research from T1 to T2, which is basically deliver the recommended care to the right patient at the right time. I think that's the most important.
You're right, Marta. Your opinion is, as you know, very important for me and for us, because you are an expertise 36 degree as a clinical and as a researcher, as a president of an important federation, and also a member of WHO. We have not many time, and the topic of research and rehabilitation is one of the most important topic. I work in an institute of research, but for example, in neurorehabilitation, many work of research in neurorehabilitation are addressed on basic research, on neurological research, not on the translation of research from basic research to clinical practice. We know that the translational research has many caveats, has many stops, has many blocks, but we have not so many work. And in particular, as we introduce about the data, we have a trial with not so many patients. Our trials are very limited. This is a problem for us. We have not so many time because, but we have not finished our World Brain Day. But I would to present you this experience on angles, because when we propose the program, the scientific program of this day, it would important to know the opinion of a family. As you know, Nangel born as an initiative of family, of parents of one woman who had a stroke, and this important person, because as you underlined, we need found to have a good research in rehabilitation. He had found, and he organized this project. Then, unfortunately, Lorenza Spagnuolo, the speaker, representative of Engel for Europe, is not here now because the time is very, very, very late. And so she sent us the video. Then to conclude this round table, and I thank all the participants also for their patience to be here still today in this time. and I would to present the video from Lorenza. I ask to you your contribution, for your contribution. Christian Gocchieri.
Good afternoon, everybody. Thank you, Dr. Pistarini, for the introduction, especially for the invitation for this webinar. It's really a great pleasure for me to be here today. My name is Lorenza Spagnolo. I am Regional Director for Europe for this initiative, which is the ANGELS initiative. And I'm happy today to share with you which are the characteristics of our project and of our mission around the world. ANGELS basically stands for Acute Network Striving for Excellence in Stroke. So the main goal of the project, of the initiative, is to create a global community, a global network of hospitals, but also individuals. So doctors and nurses that strive for excellence in stroke, that really try to improve their performance in treating stroke patients. ANGELS is a non-promotional project that is sponsored by Boehringer Ingelheim, that is implemented in the field by Acuia. The focus of our initiative is basically the ischemic stroke, and what we do is running consultancy with the hospitals team and pre-hospitals team in order to optimize the stroke pathway since the beginning of the stroke, so since the start of the symptom up to the treatment of the patient in the stroke unit. The project started back in 2014 in South Africa, but the biggest movement was launched in Europe in 2016. And after 7 years of working in the field, we are very happy and proud to share the results that we achieved. Basically, today we are active in 147 countries all around the world, and we have more than 7,300 hospitals that are registered to our global community, with more than 100,000 HCP, which are actively participating to our international community. We also managed to support the creation of more than 1,400 new stroke treating hospitals. That means that basically these hospitals were not able to treat and to manage stroke patients before, but thanks to the support and the help of ANGELS, they managed to implement stroke protocols and stroke pathway. And here you see the most important KPIs that we use for measuring the activities that we do with the hospitals, and we are happy to share that we managed to reduce of almost 40% the door-to-treatment time that you know for sure it's crucial in the management of the stroke pathway, being stroke time-dependent disease. We also managed to support the increase of the recanalization procedure rate from almost 7% up to 13%, an improvement of the post-acute care of about 33%, which is basically measured through the implementation of stroke protocols and stroke pathway, basically in the post-acute and in stroke unit care, mainly implemented by nurses. We have implemented also quality monitoring programs, and we have almost 1,900 awarded hospitals that received an award according to the European Stroke Organization and World Stroke Organization quality criteria. And we have also implemented a new registry for stroke patients, which is called Rescue, where we have at the moment more than 540,000 patients registered. And I must say that one of the key successful factor of the implementation of the ANGELS initiative was definitely the partnership with more than 200 societies, NGOs like the World Bank, of course, the European Stroke Organization, the World Stroke Organization, but also on a local level with National Stroke Society, and also with patient support organization. And how did we manage to implement and to reach basically these results that I just showed to you? Basically implementing these 5 platforms that you can see here in the slides. The very first one is the standardization. So basically we have Angels consultant working in the field together with the hospital to implement standardization process within the hospital, but also within the network. So basically through the implementation of customized checklists with the stroke bag that you can see here in the picture that is basically used for treating the patient as soon as possible at the city. So we are working a lot in implement standardized protocol, as I said, not just within the hospitals, but also within the regional stroke network. And this is, I think, very important also to share with you. I heard during the webinar before that we were speaking about the telemedicine in the post-acute and neurorehabilitation phase. And also here in the field, we are supporting the hospital and basically the stroke network on a regional level to implement the telemedicine. How does it work? Basically, there is the hub hospital and the spokes centers. And when the patient is brought by the EMS services to the stroke patient, a telemedicine system is implemented together with the hub, and the hub and the neurologist at the hub is evaluating the patient, doing the NIHSS, having an analysis as well of the CT imaging in such a way to support the hospital in the spoke center to take the decision. So basically, we are here. The telemedicine is supporting the decision-making process. Second very important platform that we have implemented is the education. And here you can see the website where you can basically also check all the support, all the materials that we have, which is the angelsinitiative.com. We have this online platform where we have thousands of materials for self-training and education. We have e-learning for EMS services for nurses, starting from the pre-hospital phase up to the acute and post-acute phase. We have presentations and video and masterclass, and also we have digital live simulations that are really supporting for the decision-making process. Besides the online platform, we also provide education on a hospital level, face-to-face, organizing, again, on a hospital level, hospital meeting, but as well on a regional and national network. We have, as I mentioned before, implemented also quality monitoring system, and we do think and we do believe a lot in the implementation of this system for really standardizing the process and reaching that every hospital in the world is reaching the minimum level of care for the stroke patients. And again, today you spoke a lot about community before, and I'm happy to share that we managed during these 7 years to create the biggest stroke community all around the world. We do value a lot this aspect. We believe in a community that is a place for our HCP to find more ideas, more sharing, and also more support. And how do we actually cultivate and boost our community? We have our online platform that I just mentioned to you, the angelsinitiative.com, that I invite you to have a look at, where our HCP basically can find all our resources. They can read about all the stories of the Angels hospitals happening all around the world. And they can also have the possibility to interact among each other and to have this live chat together with the Angels team and with the Angels consultant. But we do organize as well, which we believe is crucial for keeping the community alive, face-to-face events. So besides the hospital multidisciplinary meeting that we constantly organize in the hospitals, we as well organize very often the so-called Angels Day that we organize on a national or regional level. That is basically a 2 days event where the people, the stroke nurses and doctors have the chance to really do a hands-on training, some workshop on the decision-making, on the standardization, and really also on implementing stroke pathway and stroke protocols on a local level. So these are always customized events that we organize for our doctors and nurses. Last but not least, the core of our initiative are the Angels consultants. We do have dedicated consultants that are very passionate, motivated, and professional that are really supporting our hospitals to, again, strive for excellence in stroke. We have at the moment more than 140 consultants all around the world that are really doing an amazing job. And I hope that maybe in your experience, you might find some of these consultants during your pathway. With this, I just conclude my presentation. I thank again the board and in particular Dr. Pistarini for giving me the chance to share with you about the Angels Initiative. And I will be very happy to get in contact to you if you have any question of information or need of information. I will be more than happy to answer. And with this, I really thank you everyone for your attention, and I wish you a nice rest of the day. Thank you.
Good. This is the conclusion of our round table, and this is I wanted to show this initiative because I think it is a good experience of education of a professional, and in the future this could be helpful for us for promote some initiative like this of the world. Thank you so much. Thank you. Thank you.
Thank you, Caterina.
Ciao.
Ciao. Thank you so much, Caterina.
Ciao,
Thank
ciao,
you.
cari, ciao.
Thank you.
We can follow the next speaker. Mayowa, you are here. You have the last presentation of today. Christian, help me.
Thank you very much.
Okay.
Let me share my slide. Can you see my slide?
Yes.
Thank you very much. Yeah, I know that we've taken so much time, and
Please.
our brain, I know, our brain is getting fatigued. I hope this lecture will be a tonic.
No,
Thank
I
you very
am not
much.
tonic. It's very late in Italy.
I know.
Cognitive overload. Cognitive.
Yeah, I'll make it as stimulating as possible. Thank you very much. So we'll be discussing the global burden of neurological diseases and the neurology revolution. Neurological disorders are the leading cause of disability. We already mentioned that earlier on. $900 billion per annum for stroke alone, dementia, $1.3 trillion in 2019. What are the top neurological conditions accounting for this body? Stroke, across all the world region, is number one, apart from just two places where it's number two. That's Australasia, Western Europe. But then followed by headache disorders, dementias, meningitis, epilepsy, spinal cord injuries, traumatic brain injury, brain and other CNS cancers, tension type headache, and so on and so forth. Again, when you look at the 21 GBD regions, stroke is actually number one throughout, apart from Western Europe. And then there are other conditions, headache disorders, meningitis, and so on and so forth. These are the conditions that account for most of the burden of neurological disability across the globe. Now, when you look at these also, in 2019, look at 18 neurological disorders across the lifespan, you would also see that after the age of 30, 34, of course, the burden of stroke continues to increase. So also is the burden of dementia. As we've mentioned, these are the common conditions. Middle age, usually migraine, headaches, and early life infectious conditions like meningitis. Overall, between 1990, if you're using age standardized rates for DALIs, between 1990 and 2019, there is some reduction in some of the red spots. But when you look at the, that's looking at the rates. That's looking at the rates. But when you look at the absolute numbers, for instance, let's illustrate with stroke. It would appear as if between 1990 to 2019, there is a reduction in age-adjusted rates per 100,000 population for incident prevalence and deaths. But when you look at the absolute numbers, increased by 70%, 85%, and 43%. So this, of course, justifies the need for the WHO gap, which we've all spoken about today. This was published yesterday, the Intersectoral Global Action Plan on Epilepsy and other neurological conditions. Of course, we know that stroke is topmost, and then dementia and other conditions, of course, including epilepsy. So essentially, the strategic objectives are to raise policy prioritization, provide effective, timely, responsive diagnosis, treatment, and care, implement strategies for promotion and prevention, foster research, and strengthen the public health approach to neurological conditions. So a vision of a world where brain health is valued, neurological disorders are prevented, people affected by neurological disorders and their carers attain the highest possible level of health, equal rights, opportunities, respect, and autonomy, and they are also productive. So, and of course, this goes through prioritization, governance, diagnosis, treatment, care, promotion, prevention, research, innovation, information systems, public health approach within the context of the continuum of care. And this could actually be revolutionary, particularly when powered by a lot of things that are going on in terms of neurotechnologies, mixed reality. So the world has experienced the agricultural revolution, the industrial revolution, of course, the information revolution, and now it's about artificial intelligence and the neurology revolution. And getting these two together can actually power the neurology revolution. Brain health is extremely important because it's required for every other aspect of health, whether it's physical, mental, social, or even spiritual well-being and quality of life. And of course, for a purposeful and productive life. And we need to move from just thinking, using a disease-based model like dementia, go beyond that to eumentia, improving brain reserve, and also to promentia. So it's important to bring together all actions across the globe and across disciplines, across different professional societies, as well as across disciplines and all frontiers of human endeavor to be able to achieve and propel the neurology revolution. So it's important to identify challenges that may occur at system level that may impair or prevent movement in terms of surveillance, progress in terms of prevention, and advancement in terms of acute care and rehabilitation, and address such at provider level as well as patient and individual level. Of course, brain health is important for all the other aspects as has been mentioned, and neurorehabilitation is essential for adding meaning to life. Now there is a concept of human capital, which we all talk about in a knowledge economy. But now we realize that the most important part of human capital is actually brain capital, and human intelligence is still the most important. So it's important to enhance brain health, which is not only about cognitive and cognitive skills and emotional skills, but also about creativity. Brain skills like creativity, design thinking, resilience, emotional regulation, self-awareness, self-control, self-transcendence, systems integration, and entrepreneurship, which are all the things that make man unique as Homo sapiens and superior to any other mammal or machine that man can create. So we need to invest heavily in the brain capital. So brain health is central to every other SDGs, and brain health must be treated in the context not only of the neurology clinic, but by identifying and addressing psychological factors, economic factors, environmental factors, biomedical factors, political factors, social factors, which affect brain health, not just brain disorder, but actually brain health and brain function, including creativity, and not just dementia or brain dysfunction, but actually going beyond eumentia to promentia. What are the factors that make the brain function optimally, maximally, and superlatively? How can these factors be played up? Just like we are also doing to enhance artificial intelligence. How do we enhance human, collective, and individual intelligence? Of course, this is going to involve a whole of government approach and synergistic global movement across a lifetime, and of course, a life course, holistic socio-ecological approach. Again, spanning the whole spectrum of the neurology quadrangle. And then using other forms of advancements like pan-omics, multi-omics, proteomics, genomics, transcriptomics to help with personalized medicine, personalized rehabilitation, personalized surveillance, biomarkers for prognosis and prediction, and of course, clinical trials and new interventions that can help improve brain function. To illustrate some of these that we've done on the African continent, we characterize the leading risk factors for stroke, identify something very ubiquitous and cheap, readily available, which is vegetable, as something that is very important in promoting brain health and in preventing strokes, preventing even stroke severity, as well as stroke fatality, and hypertension, which is the most important the leading preventable risk, preventable factor for death. So it's important to identify the entire spectrum and cascade of factors that can damage the brain, and also to apply primordial and primary prevention at the proper places. Of course, we know that stroke usually is due to hypertension, obesity, pre-diabetes, diabetes mellitus, dyslipidemia, all of which leads to atherosclerosis and then causes dementia, stroke, or ischemic heart disease. But we also know that these factors are themselves influenced by political, legal, ethical, anthropological, socio-educational, and economic factors, as well as genetic factors. And of course, behavioral risk factors. Again, behavior depends on the brain and brain health and mental health. So tobacco, stress, air pollution, all of these can lead to these intermediate risk factors and eventually damage the brain. So it's important to apply primordial and primary prevention to prevent brain damage and preserve brain health across the globe. And there are some interventions we've developed in Africa, the stroke risk calculator, as well as the stroke educational video, which we've been able to apply to improve risk factor control and of course surveillance. Then improving brain and vascular health at the population level. In Norway, between 1990 and 2019, the standardized incidence rate decreased significantly for dementia by 5.4%, for ischemic heart disease by 30%, for stroke by 35.3%. How are they able to achieve this? This was made possible because they had a national NCD plan, which was able to address the major factors, not the intermediate risk factors, but all these political, legal, ethical, social, educational, and economic and environmental risk factors, and thereby they were able to reduce the burden of the intermediate risk factor and therefore stroke, ischemic heart disease, and dementia. That's a good example that can be followed in this era of the neurology revolution to ensure that our brain function is preserved across the life course. So it's important to address brain health determinants, some of which are physical, some of which are socioeconomic, by providing healthy environments, learning, safety, security, and optimizing brain function across the globe. So neurorehabilitation is very important to progress not only along the neuroplasticity, biophysical model, but also along the psychospiritual model. It's been found that the burden of pathological changes in Alzheimer's disease, in those who have a high sense of purpose in life, does not correlate directly with the burden of disease, which means sense of purpose in life modify the association between the global measure of Alzheimer's disease pathological changes and exerted a protective effect. This is something that needs to be investigated further. The supreme purpose of life, of course, is to achieve true and perpetual life. True life cannot be mortal. So these concepts are very important to understand. Quality of life is important to understand essence of life and, of course, purpose of life. The supreme purpose of life, according to Plato, so when the soul is firmly fixed in the domain where truth and reality shine resplendent, it apprehends and knows them and appears to possess reason. When perfect and fully wins the soul, so as upwards. And Aristotle also said, if reason is divine, then in comparison with man, the life according to it is divine in comparison with human life. But we must not follow those who advise us being meant to think of human things and be mortal of mortal things, but must, so far as we can, make ourselves immortal, strain every nerve to live in accordance with the best thing in us. Again, this is about thinking, and this is about the brain. So, and of course, the ultimate goal is to help everyone, including those who might have neurological disabilities, not only to fulfill their physiological needs, safety needs, but to aspire and actually reach and attain cognitive needs, creative needs, aesthetic needs, self-actualization, transcendence, and productivity. So whole person medicine expresses itself in no better place than in brain health and neurorehabilitation. And spirituality has been contributing to this, and there is a growing interest in the medical circle in understanding and defining that. So spiritual evolution and ascendancy, all of these are very important.
I stop after Mayowa.
Okay. I'll finish very soon. So philosophical anthropology, the Atman's model, there are a lot probably we need to learn from our nature and our supernature, from some concepts that we do not fully understand, like extrasensory perception, out of body experiences, and so on and so forth. So, and of course, the disability disparity. Now, energy therapy, logotherapy are things we need to look into to further improve our options in improving brain health across the life course. Motivational psychotherapy, spiritual psychotherapy, motivational artwork, spiritual music therapy, and so on and so forth. But we have to also define spirituality. And at the center of spirituality, it's life, is truth, and liberty and freedom. So communication, cognitive impairment, and depression are things we need to address. While those are challenges in trying to delve into this realm and communicate with patients about spirituality, we also need to work with other experts. And yeah, for the neurology revolution, it's of course we rely on artificial intelligence, neuro implants, brain-computer interfaces, all of which we've discussed today, neurotransformics, of course, the One Health, brain health, the WHO initiatives, but also neurophilosophy, medical sociology, spiritual psychology, and so on and so forth. So much has been said today about neurorobotics, neuroimplants, about artificial intelligence, generative artificial intelligence, and how these can be used or abused, and how this can be helpful. And brain-spine interface also, and the Human Connectome Project, neurotechnologies, a lot of investment on this. And of course, augmented reality, Human Affectome Project, Human Brain Project, stem cell, One Earth concept, and the neurophilosophy of rehabilitation itself, neuromusicology, ethereal arts, surreal arts, and spiritual psychology. Ultimately, the goal is to be able to apply neurorehabilitation and the neurology revolution to enable most people, or as many people as possible across their life course, to attain their ikigai, fulfilling their mission and passion in whatever vocation or profession, and achieving the peak of the Maslow's pyramid. That is what the neurology revolution is all about. Moving from the concept of dementia through dementia to actually promentia, and involving as many people as possible. And we're doing this across different fronts, different organizations and networks, and a lot of other conferences we're going to be having on the African continent. Thank you very much.
Thank you very much. Thank you very much, Mayowa, for your presentation. And now we have the last speaker, Feng Wayne from USA. Christian, he had some problem with the link. What we can do? No, Wayne.
I'm
Wayne.
here.
Ah, you are here. Okay.
Yes, I've been here.
You're welcome.
Hi there, Wayne. Good to see you. Good to see you.
How are you doing, Wayne?
I'm doing good. When Katerina said Maya was the last speaker, I got desperate because I'm the last one.
because I thought you had some problem with the connection. Only for this.
No, I'm here. I'm in the car, but I'm good.
Thank you so much to be here.
All right. Let me know when I can get it started.
Yeah, now you can start.
Okay. Can you guys hear me
You
okay?
say your slide.
Can you hear me okay?
Okay.
All right, very good. Well, good morning, good afternoon, good evening. My name is
Good
Wayne.
night.
I'm sorry.
Good night.
Yeah. My name is Wayne. I'm at Duke University School of Medicine. I am a stroke neurologist. What I'm going to talk about today is really to link acute treatment, prevention, recovery together, and as an integrated stroke care approach to maximize stroke outcome, what I call the preservation, prevention, and plasticity. So in the next 30 minutes, we'll really kind of talk about how we can maximize and post-stroke outcomes. So my disclosures. This is the objective for the talk today. You know, there are two different types of stroke. One is ischemic stroke. You have a clot. The other one, the hemorrhagic stroke and the pipe burst. And the ischemic stroke is about 70% of total stroke. And a hemorrhagic stroke about 30%. There's a lot of breakthrough with the ischemic stroke. So the talk today is really centered on ischemic stroke, just for the time purpose. The first step is really treat early, preserve the brain. As we all know, time is the brain. And Jeff Say from UCLA really, quantifies this brain loss through the stroke. Basically, the time of stroke every minute, there's almost 2 million neurons, is losing. So when it comes to acute care, really come to minute, come to second, and really get a patient and fast treat it. And so we now have almost 2 medicine. The one is very mature medication called Altiplase or RTPA. Really shows there's 13% of risk reduction. And if we give the medicine within the 3 hours, and if we give the medicine and between 3 and 4.5 hours, the benefit still persists. But the benefit kind of a little bit smaller regardless, and it's a pretty mature and a treatment now give the RTPA within 4.5 hours. Now we can also give another medicine called a TNK within 4.5 hours as well. Beyond 4.5 hours, you really have to do and a multimodal imaging, try to select those patients with a mismatch, means there's not many tissue dead, but there's a lot of tissue at risk. And then through the endovascular approach, and the pipe can go through growing area and go to the area had a clot, then can take the clot out. And it's just really revolution and the care and a patient got a significant better after recannulations. And it's just all written into the guideline in the US and worldwide right now. And the golden hour concept is really raised by Dr. Adam Coley, basically saying, there is golden hour between life and death. Does not just apply to stroke, apply to massive bleeding and respiratory and issues and a heart attack. You really need to bring to the hospital within the 30 minutes in order to survive and get a good outcome. So this is similar to the stroke. If you treat a stroke patient within the 90 minutes of the stroke, and all you need to treat every 2 patients, 1 patient will do well at 3 months. If you do 2 hours, the benefit actually dilute. You have to treat 4 patients in order to have 1 patient benefit. But if you delay another hour, treat a patient 3 hours after the stroke, you have to treat 9 patients in order to have 1 patient and getting better. So the concept is really, and if you delay, you lose the brain. So time is the brain. With this, American Stroke Association come with different metrics, and they call it targeted stroke honor roll. Requires 70% of stroke patients need to be treated within the 60 minutes after they come to the door. And a stroke honor roll elite status means 85% of patients will be treated within 60 minutes. Elite plus, really the highest means 50% chance, 50% patient have to treat it less than 30 minutes. 75% of patient treated less than 45 minutes. That's pretty tough metrics, but that's really linked with good outcomes. The stroke honor roll advanced therapy really apply for endovascular therapy means with 50% of patient and have to be treated within the 90 minutes once they arrive to the emergency room. If the direct transfer have to be 60 minutes. So those all really and ask neurologists to treat a patient in a very timely fashion. So how we can treat them more, just a moment, we still only treated less than 10% and a stroke patient. There are various issues, okay? So we need to treat more stroke patients. So how we can treat more? We need to build a more stroke center, okay? In the US, there's an incentive for the payment for the hospital to build a stroke center. If you treat a stroke patient with TPA and a thrombectomy, the hospital will reimburse with the double money, and then for the patient you didn't treat with the thrombolytics or endovascular therapy. Patients are educated to get in emergency room and as fast as they can. We use a fast, face, arm, speech, time to call 911. Outside the United States, you call 120. Or you can use a telestroke approach so we can treat a patient in the rural area. Or if a patient doesn't come to the ED, we can reach out the patient. That's called a stroke mobile units concept. Through all this, in the next 10 years, we hope to treat more and more stroke patients. One day we hope to treat stroke patients, just treat like pneumonia, with all the antibody we have. Right now, we're going to treat 10% of patients. One more slides about a telestroke. This is South Carolina, deep south, and one of the poorest states in the U.S. in the buccal stroke belt. Before telemedicine, there's only 50% of patients covered within they drive 1 hour and then can get it treated. With the telemedicine approach, they drive 1 hour and 90% of population covered by the telestroke network. So this is really a revolutionary care and the outcome significant and a changer and the mortality decrease and disability and a decrease at 3 months. Again, just point out, if patient can't come, you can drive the stroke mobile units, which house a CT scan, and you can drive, to the patient. The only limitation really only apply to very densely populated bigger cities. Small city or rural areas, it's probably not going to work. Now we have a good evidence to support to use stroke mobile units. This is down to Houston in the U.S. Really suggesting for the patient with acute ischemic stroke and treat the patient with stroke mobile units were linked to and a better outcome in the 90 days or less disability and in the 90 days as compare patient treated in emergency room. So we just talk about how we can treat a patient, preserve the brain, so the brain can be better condition to recover. But the second step is really to prevent a recurrent stroke, to prevent the further brain loss. So the brain will get a better chance to recovery. We are saying preventing strokes is almost equal to preventing dementia, right? So if you brain loss, you have a better brain, you're less likely to demented. So how are we gonna implement this? We need to implement etiology-based second stroke prevention regimen. We need to make a good, accurate diagnosis. We determine what exactly causes stroke, okay? And then we prescribe specific and prevention regimen. And this has come from his email officials. And he always educated his fellows and say, if patient come back with another stroke, it is your fault, okay? He lived in a time we still don't have much acute treatment, but all he can really emphasize second stroke prevention, figure out the etiology. So how we do the etiology? The wider concept is use Toaster criterion and to classify the patient with large vessel disease, small vessel disease, or cardioembolic disease. Unusual cause typically have dissection, hypercoagulability, genetic issue, or they are patient we still don't know. Here on the right side, just want to show you if patient have more than 70% symptomatic carotid disease, you should treat with a carotid endarterectomy or carotid stent or through the TCAR procedure. And if you do this, and the risk to have another stroke is significantly decreased. Really highly important how we determine etiology, how we can treat a patient properly. Okay, there's a lot of embolic stroke undetermined source, means we think they are embolic, but we are not sure. There's a revolution and a lot of technologies. Some are low cost, basically those heart monitors, and we can discharge a patient with a heart monitor, and we detect a very high level of the atrial fibrillation or other arrhythmia, and then we're able to put a new anticoagulant like a dabigatran, Xarelto, and Eliquis, and so the much better medicine than older medicine, Coumadin, which can have a lot of issues in terms of patient compliance, safety issues. So really, those are really revolution second stroke preventions. Okay. So how we can control other stroke risk factors? Those are easy to say but hard to do. But American Heart Association said life is simple 7 approach: stop smoking, eating better, lose weight, get active, know your cholesterol, control your cholesterol. There are a lot of cholesterol medicines, statin, PCSK9 injection. You can just do once a month, and reduce your sugars and control diabetes, know your blood pressure, manage your blood pressure. There are so many medications, and if you take the medicine, you have a good chance to control the blood pressure. Again, I want to emphasize the blood pressure is the number 1 risk for stroke for both hemorrhagic, ischemic stroke. You control blood pressure, you control almost 50%, and prevent 50% of stroke. So our third step is really use another P, plasticity, use the brain plasticity to recover the brain and the body and get them well. Despite what I just mentioned about all the revolution in acute treatment, stroke still remain as a leading cause of disability in the US and worldwide. There's so many complications after stroke. There's pain, there's the spasticity, there is urination and incontinence, there's a sexual dysfunction, communication issue, cognitive impairment, seizures, mood issue, and patient have trouble with handle the ADL. Among all those complications, the motor impairment is the most common complication after stroke. Here we just use motor recovery as a way to show you how we should use the brain plasticity to recover the brain. So first, let's understand the post-stroke recovery process. The initial injury is the major determinant of stroke recovery. Again, we can do all those stroke recovery work, but again, the initial injury. If you can give the thrombolytic, preserve the brain, have minimized initial injury, patient is at a good chance to get it recovered. Okay, if you put a second stroke regimen, you can prevent another stroke. A lot of time we say, oh, the patient recovered pretty well. Then next week you hear is patient suffer another stroke. Then you have to start over again. Okay. So other things, get a patient adequate therapy. You can speed up the process. Treat depression, all those things can modify the recovery process. For motor recovery, it's also important to assess the recovery potential. The corticospinal tract is the neural substrate for recovery. You can assess the patient by clinical exam. You can do TMS to look at the evocal potential. You can do structural imaging to look at the connectivity of the corticospinal tract. Or you can do functional MRI to look at the text-based and the motor signal and to look at how the brain network was respond in the setting of a stroke. Persistent from New Zealand really come up a way called a PrEP algorithm, really combined with a clinical assessment, TMS, and imaging, really can predict and recover pretty well. It first uses SAFE, and shoulder abduction, finger extension. Look at one proximal muscle, one distal muscle. If you have both and movement, and within the 48 hour, typically those patients will have a good recovery. If they don't have a good SAFE score, you do TMS within the 5 to 7 days. If you can evoke and motor evoke potential, those patients will likely have a good, notable recovery. If you don't see MEP, you do MRI scan to look at it, and look at a corticospinal tract. Here, they just look at it and fractional endoscopy at the posterior limbal internal capsule, compare the injured side with the healthy side. If the ratio is not bad, means those patients still have some degree of recovery. If the ratio between the healthy side and injured side is too big, means the corticospinal tract probably is severe injury. The chance to have a good and meaningful recovery probably is low. So that seems to make sense of the algorithm, but I also want to point out, you need to TMS, you do the research imaging. That's not a very cost effective. Can we have something just low cost, and just do imaging, imaging is available literally everywhere at this moment in worldwide. Here I just want to show the example. Our lab come out called weighted corticospinal tract lesion load. Basically, all you need is a clinical MRI scan that you use to diagnose stroke. But all they can tell you is if they have a stroke or not, how big it is. And then what we do is we overlay the diffusion weighted imaging on a database with all the healthy control and with the probabilistic and a corticospinal tract. Then we do slide by slides and voxel by voxel. So we really can highlight and to know, how much the stroke really injured the corticospinal tract. The picture at the bottom really can show you, and the blue part is the overall stroke lesion. And then the red part is the descending corticospinal tract. But the purple part is the part of stroke and overlap on the corticospinal tract, or the part in the corticospinal tract injured by the stroke. So let's look at the three examples. The first example, the patient had a very large lesion, also very large and lesion to the corticospinal tract. This patient didn't have any improvement. Fugler score is 4, 3 months still 4. Second patient is a distal M1 occlusion, spare the subcortical area. And lesion is pretty big, 122, but the part that injured the corticospinal tract is much smaller. It's on 5 cc. And this patient, Fugler 5, 3 months increased to 52. Okay. You see the difference. And patient C, it's those are subcortical stroke related wide matter tract injury. Only 20 cc of a stroke volume, but more than 1/3 actually injured the corticospinal tract. So this patient only improved from 4 to 12 points. Really to show you the size of the stroke doesn't matter. What matters is the part overlay on the corticospinal tract. That's what matters, right? So the figure on the right side to really can show you, and the lesion at a 7 cc on the corticospinal tract is likely as a threshold and for meaningful recovery. If lesion load is less than 7 cc, patient likely have good recovery. More than 7 cc, patient have less odds to get a recovery. So, but we probably need to define the threshold a little bit better. Okay. Here I really want to show you the good evidence for stroke motor recovery is really, in a high dose of therapy, such as a constraint-induced movement therapy, and you should really, in a stroke patient, have to practice 6 hours and then have to go home and wear the men to continue practice. That's how you trigger the brain and to have a plasticity, so now the brain stimulation really give us a lot of hope, such as vagus nerve stimulations. It's published on Lancet, really can show you for every 4 patient we treat or every 3 patient we treated, there's 1 patient, will have a significant reduced motor impairment, or every 3 patient you treated and the patient and arm function was significantly improved and measured by the Wolf motor function test. It's not a very big procedure and the FDA approves this, but even it's not a very big procedure, it still costs a lot. In 2 years after the FDA approved the device in the US, and there's only less than 50 patients benefit from this procedure. Most insurance company doesn't approve this. So I think the cost is the issue, okay? So with this, we need to think about a non-invasive and device such as transcranial direct current stimulation. Probably with a couple $100, you can put a device together. It's portable, it's safe, and you can use as adjunctive therapy with a physical therapy. This is a study what I'm leading in the U.S. It's called Transport 2 study. That's the largest TDCS stroke recovery study, and we are finished 81% enrollment, and we hope to finish the study in the next year, and then hopefully can share with some the results of the study. And if the corticospinal tract is significantly injured, maybe you can do nerve transfer. This published in New England Journal of Medicine really cut the C7 nerve and wrap around the neck and connect to the other side. And that means, once you have a stroke, the healthy side can control both limbs. And that seems can, significantly reduce the spasticity, improve the outcome. But it's a big surgery. It's a big surgery. And at Duke, we try to start this clinical program, hopefully to help with some of the stroke patients. So this is a very innovative approach. Okay. Other things I want to do to time, just going to highlight here. There are quite a few of emerging therapy, such as epidural stimulation in the cervical spinal cord, or you put a cortical level. There are some promising data, and it can be improved post-stroke outcome. Deeper brain stimulation, position at the cerebellum, and really target the downstream of cortical spinal tract shows promising data. BrainQ, Israel device company use called a low frequency, low intensity electromagnetic field stimulation. Right now in a phase 3 study, hopefully we'll know the results and in the next year. We talk about endovascular therapy, retreat, but they can also put electrodes in a suprasagittal vein, which is right above the leg cortex. You can stimulate the leg cortex, with minimum invasive procedure, okay? And as a sartorial device, you can also make it a recording device, or it can be stimulating device. So I think that's all possible in the next 10 years. Do want to touch base about spasticity. We need to treat spasticity. If you don't treat spasticity, the central nervous, once spasticity develop, it's not the brain problem. It becomes a peripheral problem. It becomes the tendon issue. It becomes the muscle issue. It becomes the fascial issue, and they're just not going to benefit from this. Once they develop and a contracture, they just cannot. And we really need to know at this moment, it's not a brain issue, it's a peripheral issue, it's a combination of both. So I'm always very big to treat the spasticity, to preserve the arm in the natural condition so they can be better for future therapy. Again, here I just want to summarize on the recovery part. We spent a lot of time on recovery. For minor stroke, I think we have good evidence. We just need to increase the dose, convince the insurance company to provide more therapy, and those patients can live live normal. Moderate stroke, they're still neurosubstrate. The system not a crash. You can do intensive therapy plus brain stimulation. We can help patients live near normal. Okay. For a severe stroke, we have to acknowledge it. There are bad strokes. There's very minimal or no neurosubstrate left. We probably have to introduce exogenous cell, exoskeleton, brain-computer interface. We are not going to help them to live near normal, but we can help patients to find a different way to live. With all this, again, I want to emphasize, let's preserve the brain in the first place by aggressively treating all those stroke patients with thrombolytics and endovascular therapy. Let's use TOAST criteria and define the etiology of stroke so we can prevent the further brain loss. Then we engage the patient, use brain plasticity to get a brain recover and get a body recover. In this way, we can maximize the stroke outcomes. This is my labs. I'm going to stop here. Thank you.
Thank you, Wayne. This is the important update about the care of patients with the stroke and the final lecture of this day. Let me say some closing remark about this day. And I kindly ask to Christian to have my final slide to summarize the Day of Brain Health and Disability. No one must be left behind. We saw the current situation of brain injury today. We face aging population, long-term illness, promptly diagnosed, more treatable, even not curable, that accompany person for many years of their life, that determine disability and loss of self-sufficiency, that determine social fragility of patients and their family. Next slide. What we need? We saw that we needed to consider the care pathway of patients with brain injury, not only under the biological profile, but also we must pay attention to its personal, social, and cultural dimension. And we need to understand and to apply our appropriate intervention program and to provide appropriate service. For this, we have to overcome the epistemological concept which underpin the biomedical model to meet another model, ecological model of individual human functioning. We said this term in all of the intervention that we provided during this day. Next slide. Then, to enhance neurorehabilitation capacity, we must involve all the stakeholders that are not professional, not only family, but also healthcare provider, social workers, politics, because of the collaboration of stakeholders serve to conjugate our data, and we hope to have many data about our patients with brain injury from clinical rehabilitation intervention with the effectiveness, efficiency, appropriateness of our intervention. Then, last slide, we can consider our neurorehabilitation as an engine to apply an integrated approach to optimize the person's skill after brain injury disease. And we can consider also neurorehabilitation as a tool to achieve the maximum degree of social inclusion and participation. Our commitment is the necessary knowledge about intervention, about their cost, about their coverage, to avoid negative consequences in terms of poor health, in terms of inadequate responses, social welfare, and economic issues. This is the sustainability of our system. Then I thank you your kind attention. We can conclude with the last slide. I thank all the speakers of this day. I thank the organizer of the community-based rehabilitation part. I thank Daphne Morosano as president of WFNR. I thank our collaborator and the member of WFNR. Thank you so much.
Thank you, Katerina. Dear Wayne, it's so nice to hear you.
Yes, let's see you.
Have a nice day.
Yeah.
Have
Bye-bye.
a nice day. Thank you. Bye-bye.
Good night, good morning.
Bye.
Bye-bye.